We are live. This is Senate Finance on Wednesday, April 17th. And we are going to start today with Jill Remick from Property Valuation. And Jill, come on up. The question came up yesterday. If I one. Okay, we have in this bill telecommunications property equipment. I think you've asked us, the bill is passed by the House. This is page 35. Now that is it. Yeah, where we are. Anyway, you asked us to put period after what would be taxed after, I think it was cows. And the question has come up. There it is. So on page 29, then we left out machinery, distribution hubs, splitters, switching equipment, routers. But we still have in wires, cables, conduits, pipes, antennas, poles, wireless towers. And the question was, how do you determine fair market value? And can you do this with the appraiser? And I'm not sure if that's a contractor or a full-time employee that you have. How do you determine that? What's the way, the standard? Yeah, there's 3 standards for appraisal. And how do you do it?
I brought it's 1 page. I thought that'd be all right to still bring paper.
Yes.
It's just a table of the different utility statutes and treatments. It kind of puts all on 1 page.
That would be really helpful.
And I'm sorry, this is actually from a report we did a couple years ago. So right now, we do capture the inventory for cable and telephone.
Okay.
And so as you can see on the table, the internet provider doesn't really have its own, telecommunications doesn't have its own treatment right now, but generally speaking, those things are collected by either that sort of umbrella of it being a telephone company, in which case they pay the telephone personal property tax.
Right.
Or the cable, if it's cable broadband, that typically goes under the cable, if the municipality is exempt or not. So, the expectation, I think, here is that anything that's part of that sort of real property that's related to your infrastructure, right? So it's part of the actual physical system.
But not the business equipment.
Not the business equipment. Right. So that is much more sort of straightforward. I sent you folks a report a few days ago. There's different ways different states treat those, but a lot of them are sort of wrestling with the same things. How they treat business personal property and how they treat the actual infrastructure. If this business personal property definition gets changed this way, I think that causes some, that makes it a lot harder to value. Most towns actually choose not to tax business personal property, even though they have the ability to, because it's a pain in the neck.
Could still do
They
that.
could still, and I don't think they want to lose that ability.
And they would also, this came up from the VAWA representative yesterday. They would also, if they tax it, they would also see the transmission equipment would also be going on their grand list, so they could tax that too.
Right.
Okay.
Right.
That's what we got, but I got some double check. Thank you.
Relatedly, I recall Lister raising a concern about if the appraisals from the PBR that they conduct are aggrieved or questioned, they want to make sure that the local town listers will not have a burden to have to defend an appraisal that they didn't have a part in. Could you describe what that process looks like, and would you suggest any language to make clear that the PBR appraisal process would go through PBR area and not the local towns?
Yeah,
Grievances.
we definitely do that already with a lot of the different utilities, right? There's a lot of them that are already prescribed, that the lister doesn't have to establish their own fair market value and therefore defend it. There's lots of instances where those grievances maybe they start at the town, but we would very quickly participate. We do that with hydros, we do that with cable, we do that already. So that would definitely be, I think, if we did take language, I think we would want to use the same language as is in here for.
If you could get that sample for us, that might be helpful,
Okay.
because they seem to need some reassurance that they aren't going to be stuck with the financial burden of defending your appraisal when they don't even know what
No,
way.
that would not be what would happen, and frankly, that's one of the upsides of having a statewide methodology, right? Because then the griever also has one state entity that they are grieving into, and then that would have repercussions for the rest of their treatment. So that's, there's no reason for a lister to have to defend the value that the state dictated.
If you can get us, if you want that same language, and you just
Okay.
email that over,
Sure.
that's something we can use to clarify.
And the other piece is, I just wanted to sort of mention that communication properties are kind of like the interstate or, railroad, right? The town boundary is really only our construct for the purpose of collecting property tax. It's not really how these systems are valued. They kind of need each other, right? So, it really is very standard practice. You sort of value these systems as a whole, and then you divvy up that allocation of property tax revenue among municipalities for the purposes of collecting it. But to have them individually valued separately standalone doesn't really make any sense in this market. Yeah.
And we don't do deals individually, right? I mean,
No, we do, believe it or not, we still do have a railroad corporate tax that my team does. It's very straightforward. We collect the revenue from, I think it's the 9 entities that have railroad, still in Vermont. It's one valuation. And then the revenue from that is distributed to the towns based on track miles per town.
Okay. Well, this was.
It's sort of a similar contract, whether it's customers or miles of line or, right.
Okay, any other questions for Jill? Senator McDonald, I thought you had some questions yesterday.
I did, we kept talking, learning about modernization.
Yeah.
The material of, materials used in the telecom, the deployment of them, and the fair market value of them don't fit any models that we currently use. We're trying to squeeze them into those models, and if you're gonna monitor, I think we were to modernize this thing, we could have a separate definition for this stuff. And then decide what the rules would be, so.
Okay.
And
Is,
how does property valuation review get stuck in trying to deal with business, personal property, machinery, equipment, this, that, and the other thing? Those are policy decisions. They might be very helpful in
I think,
telling us how we might craft this category before it is assessed and inventory.
okay, I think you could put the period where we've been requested to, we're leaving out most of the business personal property. So we're stuck with poles, wires, towers, and antennas, which I believe you. Would that fall under the expertise of the appraisal that you're hiring? That have hired?
Yeah, it could. I'm not sure just logistically if we have to contract out separately for, we're a state entity, we are required to get 3 bids. So I think this would be broader than just expanding our utility, but same principle, right? We have no business in Vermont or in PBR coming up with this from scratch. We would need to get a national valuation model that's been tested in courts and defendable and recognized. And we would use that rather than come up with our own.
I assume there would be a cost.
Yes, and I think the last version that I saw was that there was $150,000 appropriation for us to hire a contractor to do
I
that.
think I remember that being in here somewhere.
Section 13.
It's
Section 13.
section 13, okay. But that is in here.
Yeah.
Okay. I'm assuming that they know about that across the hall, but we'll let them know. And can you email only to folks and just tell them that we are looking at 657 and there's $150,000 appropriation in it? Just so when they're fine tuning, they know that's there. Cause I guess they're still fine tuning and, it's coming out Friday, I guess is the draft dead date, so. Make sure they know that's there, cause I assume you will need.
Yeah, and I think if we don't have that funding, we would need more time. to Figure out how to pay for a consultant to do that work.
Okay, but is the, section in miscellaneous tax, which is now in the probes, is that also contingent?
Nope, that's
No.
already under an existing appropriation that we have, that's already underway and a
So
standing
that's
contract.
what, it would be the additional appropriation
For
for
telecommunications, real property.
telecommunications. And maybe we will have to do an effective date contingent upon your ability to do that.
I think right now the language has this effective for the next grand list, which is not too far away,
Okay,
a year away. So if we were required to do it, we'd want to do it right.
yeah, yes, because if we don't, listers will be very upset and will probably send us back to the 18th century, so.
Well, and I think it's also based on the repealing of the telephone personal property tax.
That's
So
right,
those effective dates would have to,
all work. Okay,
but I
and I
didn't
need
mean
to
to send
help
you
us
down.
make it all.
Hopefully it's a
work.
non-issue.
All right.
Yeah.
Okay. Any other questions for Jill? Okay,
Okay,
thank
very
you.
good language. All right,
We
we'll get that to
will.
you. Thank you.
We will put this one to bed before we take up the yield bill, because I think we can only do one massive bill at a time. So my intention would be to get this out this week. I think we'll get the yield next Tuesday or Wednesday, but we can start looking at it. I would be surprised if there aren't some floor amendments, but we can start looking at the bill as presented and then pick up the floor amendments. Okay, thank you. All right, next I have Julie Lowell. Julie, hi, how are you?
Just connecting still. Okay. I can share my screen. All right, I'm had to yeah, this technology very much.
Would you just introduce yourself and
Okay,
who you
great.
represent?
Thank you. I'm gonna share this screen if that's okay.
Yeah.
Okay.
Okay.
Great, thank you so much for having me today. My name's Julie Lowell. I'm a policy analyst at Public Assets Institute. And we work on state fiscal policy to improve the well-being of all Vermonters and to advance racial and economic equity. So today I'm here to talk to you about Vermont's anti-poverty tax credits. And when I say that, what I'm specifically talking about is Vermont's earned income tax credit, or the EITC, and the child tax credit, which I know you are all familiar with, refundable tax credits that put cash assistance into the pockets of Vermonters struggling to fill the gap between their income and their expenses. In 2022, just to put the credits in context, they helped nearly 46,000 Vermont filers, about 14% of Vermont filers that rely on these credits. And during the pandemic, we saw firsthand the power of these anti-poverty credits. Federal government extended the child tax credit in 2021, and along with economic impact payments, 10,000 Vermonters were brought out of poverty in that year. So really impactful policy.
Aren't they trying to do it again?
They're not as not as expansive.
Okay,
As
but
was in
you know
21.
something in the works in Washington.
There's potential, we're following it, but I'm not clear on, I'm not a
Well,
betting
I don't
person,
spend
but.
any money that's coming to Washington these days.
But what we saw from that experiment was people use these to cover the basics, and food was the number one thing that people were using these resources for. So since then, Vermont has done amazing work, right? We've expanded the EITC in 2022. We implemented our own child tax credit for kids under 6. It's been very impactful. And so what I want to show you today is just sort of the impact. Sorry, my technology is. Okay, so what we can see is if you look at these, the lowest 40%, so the lowest 20% and the second 20%, this is ITEP's data that came out in 2024 of the tax impact on our lowest 20% and second 20% residents, which is 6.3% and 8.2%. And this is what this looked like in 2018. So you can really see that the tax credits have had an impact on creating a more progressive system, as well as creating a more financial ease for families. So we've seen how impactful the credits are, we've seen what important work they're doing and could be doing, and not a surprise, some challenges remain. And this is where you can see that the poverty rate for families with children continues to be much higher than other families. And in fact, for families who have 2 kids, one under 5 and one between 5 and 17, they're facing some of the highest poverty rates in Vermont. In addition, our minimum wage, which you can see on this next chart, it continues to fall well below what a family of 4 needs to make ends meet. It's almost $50,000 short of what the basic needs budget defines as what a family needs to make ends meet. And so we know that tax credits are a part of the solution. They're not the only solution, right? Wages are an important part of this, but employers can't cover the full cost of increasing family size. And so we know that tax credits, the anti-poverty tax credits do just this, they adjust as family sizes increase. So this next chart, it just gives you an understanding of really how valuable the credits are. And so this is the value of the state and the federal earned income tax credit together. Along the bottom is the AGI, and on the side is the value of the credit. A little over a quarter of this comes from the state, and a little less than 3/4 comes from the federal government. But what's kind of remarkable about this chart is actually what you can't see. So around $44,000 here to $64,000, families stop receiving the credit, depending on how many kids they have. But the basic needs budget for a family, the lowest basic needs budget for a family with children starts at $70,000 and then goes up with more kids. So all of these families that are making more than this that aren't visible here are not getting any support. So that's one of the challenges and the holes with our current policy. The other is that if you take this family as an example, around $25,000 of household income, they have 3 children or more. Maybe one of those kids is under 6, so they're getting the child tax credit. This family is getting almost $10,000 of support. So that's super impactful, very helpful. $35,000 is this family's income now. So again, still far below the amount that they need to make ends meet. So those are sort of 2 of the holes. And then the last is this blue space right here. And this is the tax credit for families who don't, for a father without children. And what you can see is the credit's really low for this family. It's around $800 combined for the state and federal. But then it stops at around $17,000 of household income. So well below.
Which tax? That's not our child tax credit.
This is specifically the earned income tax credit on this.
Okay,
Yeah,
that's what I
this is,
thought you might be
Mhm.
referring to.
Yeah, sorry. Yeah, I switched to specifically the federal and state EITC.
I thought we raised that up more like 35, 40,000 to be eligible.
Right now, we're still paired with the federal. So our EITC is a percentage of the federal credit. And so we haven't changed that.
Okay,
So this is like currently all of Vermont's EITC benefits just flow from the federal. So that's a problem for our lowest earners. And the other piece, again, that you don't see is that for this blue earners, I'll call them, you're only eligible for this if your age is 25 to 64. Again, that's a federal qualification. So our youngest and our oldest workers who are earning the least are not getting any support from this credit. So over the last 2
What's
months,
the logic on that?
it's like a very bizarre history where they added this to compensate for a gasoline excise tax in the, don't quote me on this, like sometime in the 90s. It's not, it wasn't driven, I think, by like a sound policy engagement. Or at least not by trying to meet their basic needs fully.
But there is a state component to the income tax credit, and I know we have raised that.
So yeah, so right now it's 38% of,
Okay.
and I can tell you actually. So the maximum federal benefit $600 and an individual without kids, the max benefit they get is $228 from the state this year. So I've been working over the last 2 years in coalition. Oh, this is why I should have shared the whole screen. You weren't supposed to see all 3 of these yet, but I'm having a hard time sharing the display screen. So I've been working with organizations, really focusing on using these tax credits as a tool to help people meet their basic needs. And really recognizing the positive impact they've had and that it allows families to direct their financial resources in a way that's going to be most impactful for them. So our coalition has identified these 3 areas that we could improve our current policy. And so the first is to expand the value of the credits. In particular, I know I've talked about both the child tax credit and EITC today, but this session, we're really focused on expanding the EITC. House Bill 701 was introduced in Ways and Means, and that would increase the state EITC to 55% of the federal for filers with children, and to 100% of the federal for filers without children.
Do you know where that bill is?
It is still in Ways and Means right now.
Okay, and it's an H bill,
It is H bill.
which they have minimum ability to get here.
Yes.
And we voted out miscellaneous tax because the budget was supposed to come out on Tuesday.
Okay.
So at the moment, I don't have a vehicle to do this.
Okay.
Um,
Totally understand. And something I want you to
it
always
is late
keep
in the
thinking about.
session, yeah.
Yep. So that's one of our big pushes. But the other thing, and again, depending on timing, but we'll talk about it here, is really recognizing that we know that those 18 to 26-year-olds, or 18 to 24-year-olds are cut out of the bill. And we know that of that age group, former foster youth are particularly financially vulnerable. We'd love to follow what California has done, which is introduced a tax credit targeted towards former foster youth. And we've been looking at the baby bonds bill as a way to as a nice companion piece to sort of recognize this place of financial vulnerability during this time of people's lives. This could be a really good fit there. The other piece that we'd like to do is extend the credits to those left out. So, we're going to continue to push over the next biennium as well to try to include all of those workers, not, the youngest and the oldest workers as well. And to start extending the child tax credit to other vulnerable populations, in particular families who have a child of any age who has a disability. We know that these families could really use some extra financial assistance. And then the last piece is really making the tax credits easy to access. And so we've been working really closely and starting to have conversations with the tax department about how do we make sure that everyone files for these taxes, because if you don't file for them, which you don't have to if you have very low incomes, you don't get them. And so we know that was about 20% of filers in 2020. So we want to make sure we're getting federal resources in and that people are able to access the credit. So thinking about simplified filing, connecting to the IRS direct file program, which piloted this year. And making sure that people who are newly eligible for the credits who don't have socials and ITINs have trusted community partners who can help them file, which unfortunately this tax season we did not.
Okay, I thought the CAP agencies had tax filing services.
They do, and we're running into an issue because they're IRS funded, that they are not allowed to serve people who don't have a social or are applying for that ITIN. And so
Who don't have a social.
So we're trying to understand the state contributes some money to those programs. As of 2 years ago, right? They get a grant from the state. So it seems as if there's a way.
Yeah, I know.
But we haven't figured it out yet.
Tell us how great the program is that we fund, so I know there's money, state money that's going in there somewhere.
Yeah, and so I think now it's like because we're in the red tape process of trying to understand exactly how because they use some of the IRS infrastructure to fund the program as well as some state dollars, so trying to figure out how do we untangle this so that we make sure that all our residents can get the credits.
Okay,
Thank you so much for having me today.
thank you. Next year, see us early on.
Okay, that sounds great.
When I've got vehicles.
I'll be in touch.
Okay, thank you.
Thank you.
Okay, 766, Jen is not here. So I assume she's coming. So we are gonna go through, we do not have possession of 766, but it could. Allegations are that it will have a major cost impact on health insurance, and health insurance is our domain. So we're gonna take a look at it, and we can make a recommendation, or we can do a floor amendment if we feel so encouraged. But I'm waiting for Jen, who I know is tied up in another committee. I've only got a quorum, so if I give you 10 minutes, I won't have you for 20. There's Jen. We're keeping the chair warm and drinks.
Sure, I just drink a lot of coffee, so usually every 75 minutes.
Okay. We can all go one at a time. Then we will come back. I don't know where, well, I know where Senator Gray is, he's been called from the house. I don't know when I am. So Jen, you just walk us through the bill.
Okay, you know,
We have copies.
okay, so you don't want language up? You just wanna talk through?
I'd like to think. 766, we do have copies.
Okay.
Can you share screen, so,
I can, I just need the to,
okay? We go all can see what we're.
I don't see that internet, no.
They tell me to turn on and off my iPad. We're at the end of the hall.
Now,
Well, we can't do it, we'll just.
no, I am on. I'm on the internet, and I have other things to have catching up there, so. See?
Yeah.
Even for your business. For the record, Jen Kirby from the Office of Legislative Counsel, we are looking at H 766, an act relating to prior authorization and step therapy requirements, health insurance claims, and provider contracts. There's lots of different pieces in this bill. So refer to my section by section, this is easy. The first section amends our statute on prescription health insurance covered for prescription drugs, and specifically in the area of step therapy. Step therapy is generally when an insurer or other payer requires a patient to take drugs in a particular order. So maybe take something that is a cheaper version before trying a brand name drug, or try something that is otherwise
A generic versus.
right. It might be a generic versus a brand. It might be different mechanisms of action. But there's certain order in which they must take the prescription drugs in order for them to be covered.
And these all came out of our efforts to control costs prescription drugs?
Well, this has been from the insurance side. This is something I think the insurance companies have set up
Okay.
over time.
I thought we had also passed laws in.
We have a generic substitution requirement that is on the pharmacy side. This is really the health insurance.
Okay.
All right, so we have an existing law that addresses step therapy. This amends provisions of it under the existing law. A plan that provides coverage for prescription drugs and uses step therapy protocol cannot, this is existing law, require failure on the same medication on more than one occasion for continuously enrolled members or subscribers. This keeps some of that thought, but adds more to it. So first it says that a plan cannot require failure, and it specifies including discontinuation due to lack of efficacy or effectiveness, diminished effect, or an adverse event on the same medication on more than one occasion. And then it clarifies who we mean by continuously enrolled members. This is insureds who are continually enrolled in a plan offered by that insurer or its pharmacy benefit. So, because we're gonna have a different one,
And this
somebody who's
is-
changed plans.
Say that you can't require that you fail twice before we'll move you up. What do we?
Right. So what this is specifying that part of what we mean by failure on a drug is stopping the drug because it wasn't working, stopping the drug because it wasn't just working not as well as it used to, or stopping the drug because there was some bad event, an allergic reaction or some kind of
Very naughty.
makes you very nauseous, exactly, and unacceptable side effect. For insurers who are continuously enrolled in a plan offered by the same insurer or its PBM. So if the same insurer's had eyes on this person's claims over time, they can't require failure more than once. They also have to grant an exception to their step therapy protocols upon request of the insured or the insured's provider under the same time parameters that are set forth for prior authorization requests. So we're gonna look at that in a couple of pages because that changes in the bill as well. So grant an exception to its step therapy protocols upon request if any one or more of the following conditions apply. If the prescription drug that's required under the protocol is contraindicated or will likely cause an adverse reaction or physical or mental harm to the insured. So this doesn't require the insured to have taken this drug before and failed on it. It just says they can get they have to get an exception to the step therapy protocols upon
They
request.
had a bad reaction to a similar
A
drug.
similar drug is likely to cause an adverse reaction because of something in it, or bad impact on the insured.
Trash.
If the prescription drug required under the protocol is expected to be ineffective based on the insured's known clinical history, condition, and prescription drug regimen, or if the insured has already tried the prescription drugs on the protocol or other drugs in the same class or that have the same mechanism of action, and those have been discontinued because they didn't work, lack of efficacy or effectiveness, diminished effect, or an adverse event, regardless of whether the insured was covered at the time on a plan offered by the current insurer or its PBM. So earlier we said this is for somebody who's continuously enrolled. This one is saying they might get an exception granted, even if they weren't always on this same insurer's plan. Or if the insured is stable on a prescription drug that was selected by their healthcare provider for the medical condition under consideration. So they're already taking something and it's working. Or a step therapy protocol or a drug required under it is not in the patient's best interest because it will pose a barrier to adherence. It's difficult to take, you have to take it several times a day. There's certain things about it that are gonna make it hard for the person to keep up with the regimen. Or it's likely to worsen a comorbid condition, likely to make something else they have worse. Or it's likely to decrease the insured's ability to achieve or maintain reasonable functional ability. It's gonna make you super sleepy. The person won't be able to
Super.
all right, so those are really the other changes in here are just clarified. Section 2 is on claims processing and claim edit standards. And this amends sections of statute relating to how health plans and other payers pay healthcare claims, including how the payers edit claims, apply claims edits. So we're coming back here to Senator Chitman's favorite term, CPT codes. Put that on the floor. So under existing law, there are some parameters around how, I'm just gonna call them payers for shorthand, but it's the law lists health plans, contracting entities, covered entities, and payers. So current law requires payers to accept and start processing all claims submitted by a provider pursuant to and consistent with the current version of those CPT codes, reporting guidelines and conventions, some other codes, HCPCS, which is the CMS Healthcare Common Procedure Coding System, and other standards as well, or other appropriate nationally recognized standards, guidelines, or conventions approved by the commission. That's existing law. Now we're going to get into some narrow. Except as provided in subsection C, when editing claims, payers must, and under this language would say, require not more than the following edit standards, processes, and guidelines. So for claims for outpatient and professional services, they can't require more than NCCI, the National Correct Coding Initiative, as in effect for Medicare. So claims for outpatient and professional services do like Medicare. Similarly, for facility claims, can't require more than the Medicare code editor as in effect for Medicare. For pharmacy claims, they must apply no more than appropriate nationally recognized edit standards, guidelines, and conventions. And for anything not addressed in any of those categories, other appropriate nationally recognized edit standards, guidelines, or conventions approved by the commissioner.
When you say edit,
Yes.
tell this committee, because we're not healthcare, what that means.
So, and I'm sure you're gonna hear from other people who can explain it better than I can, but when a provider delivers a service, a healthcare service, and the claim is sent to the payer may make, payers do sometimes make adjustments, make edits to the way the claim was presented,
Okay.
and then pay based on that edited claim. And so there's a sort of push and pull between the payers and the providers about what services were actually delivered, what was appropriately billed for in the claim, what should be paid at what levels. So that's kind of what we're in. This committee knows this from recent work. We're in reimbursement land here. This is what how the providers get paid
Okay.
by the payers for delivering services,
Okay.
and who's making changes and what changes can be made. And there are some appropriate edits to be made.
Right.
And drawing some lines about where those changes are appropriate and based on what criteria. All right, for outpatient services, professional and facility claims, some of the just implementation of this. If you're following what Medicare was doing, and Medicare makes a change to how what their edit standard process or guideline was, then how does that get implemented based on the time of the claim submission? So we can look at that more specifically if you want, but it's mainly just trying to implement it in a way that is workable. There's a list in existing statute and continued here about where the adherence to edit standards is not required. And this is adding a bit. So under existing law, not necessary when required to comply with state or federal law, etc. Or for edits that the payer determines are more favorable to providers than those edit standards. So it's going to be better for the provider. Or address new codes that are not yet incorporated by the payer's edit management software, but there are certain requirements. Under existing law, they must be developed with input from relevant provider organizations. Under this bill, they must be clearly supported by nationally recognized standards, guidelines, or conventions approved by the Commissioner of DFR. And then this is just updating some language, must be available to providers on the plan's website and in both its newsletters and other equivalent electronic communications. The bill would limit payers from releasing new edits more than quarterly, and gives the beginning of the quarter. And the edits shall not be implemented without filing with DFR to ensure consistency with nationally recognized standards, guidelines, and conventions. There should be a comment there. And at least 30 days advance notice to providers. And And Medicare is changing something that applies to those outpatient services, professional services, or facility claims. Then the payers are supposed to incorporate them for its next quarterly release. This next piece deals with prepayment coding validation edit review, which helpfully defines for you. It is any action by the plan, by the payer, or someone working on its behalf that requires a healthcare provider to provide medical record documentation, so provide some actual copies of medical records in conjunction with or after submitting a claim for payment for healthcare services, but before the claim has been adjudicated. So under this, it says, except as we'll see in a minute, in 2, no payer shall subject any provider to prepayment coding validation edit review. No payer shall require the provider to provide copies of medical records along with the claim before the payer has adjudicated the claim. But subdivision 2 says, but this should not be construed to prohibit targeted, so they can't do kind of blanket prepayment coding validation edit review. But it should not be construed to prohibit specific targeted review of a specific provider group, or facility under certain circumstances, like evaluating high dollar claims, verifying complex financial arrangements, investigating member questions, conducting post-audit monitoring, addressing a reasonable belief of fraud, waste, or abuse, or anything else the commissioner determines through bulletin or guidance. Most of the rest of this is just some cleanup stuff till we.
So that last section is the prior approval section?
No,
No.
we're not there,
Okay,
but it's coming up next.
it's coming up next.
We're in probably the most technical section right now,
I think
for those who are on the edge of their seats.
you all next year might want to go to health and welfare, because this is what we do every morning. Senator Chitney.
I'm glad you said this is the most technical section. On the edits, are those made by the providers globally or are they on individual claims?
They're made by the payers on individual claims, as I
Payers are
understand it.
usually the
but
insurance company.
Yes, but you will be hearing from others in the room about their, about how their organization interacts with the claims edit process.
Do we file all of the, right now, are those edits currently filed with DFR? Is that what I'm seeing in here? Or would that be a departure from current practice?
Under existing law, there's sort of a list of
Trigger.
allowable sources of claims edits.
Okay.
With a catch-all for other appropriate nationally recognized ones approved by the commissioner. But right now it's CPT, HCPCS, NCCI, National Special Entity Society Edit Standards, or something else approved by the commissioner. So this is narrowing in and getting a little bit more specific about these types of claims. This is the universe of allowable edits. For these types of claims, this is the universe of allowable.
So it's limiting the scope of what can be added.
Of the types of edits.
Okay.
Yes. Happy to be corrected by those who have more practical subject matter expertise.
I'm gonna hear from everybody before this is over.
All right. All right, so then we have some just housekeeping stuff in here. A little bit more additional information, but I don't think you probably care too much. I just want to get you to the working group. So on page 9, there was once upon a time a requested working group of Blue Cross Blue Shield Vermont and the Medical Society. They were requested to continue convening a working group that was going to look at edit standards and come up with the most appropriate way to make sure that providers know about edit standards. This is somewhat reviving that group, but it's establishing a working group of the health plans and other payers, representatives of hospitals and healthcare providers, representatives of DFR and other relevant state agencies, and other interested parties to study trends in coding and billing that the payers want to address through claim editing. So kind of look at what the issues are that the payers are trying to address through claims editing, see if we can come to some additional consensus. There would be, at this point, an annual or a progress report upon request to committees, including this committee. Basically that just continues, and it sunsets. You'll see
We're
further on
setting up
down the road, it sunsets.
to study editings. But 3 pages ago, we narrowed the ability to edit. It feels something like the cart before the horse.
Well, this group or some version of it has met before.
Okay,
Claim edits continue to be a very controversial topic in the payer provider
okay.
relations department. And so this is creating some, I don't know if they're necessarily universally agreed upon, but these are creating some more agreed upon standards for claim edits. And then having the group continue to work on what are we editing for, how can we all
Okay.
how can we all deal with this in a way that makes people happier? And this working group sunsets on January 1st, 2028. We'll see that later. All right, so now we're into prior authorizations. And there's 2 sections on prior authorizations. Section 3 is doing some alignment. So it gives some legislative intent to reduce variability in prior authorization requirements by aligning to the greatest extent possible with the requirements in the Medicaid program. And then in doing so, it directs health plans not to impose any prior authorization requirements for anything that is more restrictive than the requirements that DVA would apply for the same admission, item, service, treatment, or procedure under Medicaid. So this is saying we want to align and now directing health plans to align. Some of the implementation provisions, it directs health plans to review Medicaid prior authorization requirements at least every 6 months to make sure they're maintaining their alignment. And then there's some exceptions. So nothing in this subsection should be construed to require prior authorization alignment with Medicaid for prescription drugs. Prescription drugs can be handled differently in Medicaid and private insurance. Not construed to prohibit prior authorization requirements for anything that Medicaid doesn't cover. Medicaid doesn't cover, then the insurers can create their own prior authorization requirements. Should not be construed to prohibit prior authorization requirements for something provided out of network. That can be treated differently than in network. And not to require a health plan to maintain the same provider network as Medicaid. And then it keeps language from up above saying plans have to provide a list of services and suppliers requiring prior authorization upon request from a provider. And then a little tweak to existing law. Under existing law, a health plan must post a current list of what requires prior authorization on its website. This is specifying that they must make it available to the public on the insurer's website. So clarifying that it's not behind a subscriber wall, but just that you should be able to go on a website and see what is subject to prior authorization. Section 4 deals with the timing of requests for prior authorization. Under existing law, plans must respond to a completed prior authorization request from a provider within 48 hours after receipt for urgent requests and within 2 business days for non-urgent requests. And let the provider know within 24 hours if more information is needed. This is reducing the time for urgent requests. For urgent requests, the health plan must approve, deny, or inform the insured or the provider that the information is missing within 24 hours, not 48 hours. 48 hours is the existing law. Respond to complete. Now we're being more specific about what respond is and having it in all cases within 24 hours. And if the plan says they need more information to make a determination on the request, the plan will have 24 hours to approve or deny once they get that information. For non-urgent requests, it keeps it at 2 business days, approve or deny within 2 business days, but the plan must acknowledge receipt of the request within 24 hours and inform the insured or provider at that time if information is missing. If the plan notifies that more information is needed, the plan will have 24 hours to approve or deny it upon receipt of that necessary information. Keeps language saying if the plan doesn't respond within the time limit set forth in the section, then prior authorization request is deemed granted. And it talks about how long prior authorization approvals will last. So prior authorization approval for a prescribed or ordered treatment, service, or course of medication is valid for the duration of that prescribed or ordered treatment, service, or course of medication, or 1 year, whichever is longer. Except that for a prescribed or ordered treatment, service, or course of medication that continues for more than 1 year, plan cannot require a renewal of the prior authorization for more often than once every 5 years. And it says for someone who is stable on a treatment, service, or course of medication as determined by their provider that was approved for coverage under a previous plan, a health plan cannot restrict coverage of that treatment, service, or medication for at least 90 days upon the insured's enrollment in the new health plan. So this is transitioning someone from an old plan to a new plan. They have a little grace period to have their prior authorization, to not have to get any prior authorization as they start on the new plan. All right, getting close to the end here. Fair contracts. Oh, there's a little more cleanup in here. We got rid of references to CD-ROMs. So there's a little-
Maybe we don't still use those?
No.
I'm surprised.
And then, oh, this section is dealing with, policies. Oh, I moved because I'm done with fair contract standards. All right, so section 5 is fair contract standards. Any policies for prepayment or post-payment audits, including whether the policies include limits on the numbers of records a contracting entity may request for audit in any year. So this is part of what has to be included. Certain information has to be provided. All right, if a contracting entity uses policies or manuals to kind of supplement their contract, then the contracting entity has to ensure that they contain enough information to let providers understand and comply with the content.
Who is in that contracting agency? Providers, not providers.
This is an existing,
Payers are generally insurance companies in some form, some program, Medicaid, Medicare.
yes, so contracting entity is a definition in the existing statute, so let me
Just tell us generally what.
I think these are still the payers or somebody working on behalf of the payers. Is the contracting entity. See if I can tell you something
Okay.
more. Contracting entity, any entity that contracts directly or indirectly with a healthcare provider, either to deliver healthcare services or sell, lease, rent, assign, or grant access to a contract or terms of a contract. Okay, that's a contracting entity, and that's the language that's used in this existing section. So a contracting entity is using some other side documents to supplement the contract. They have to make sure that those additional materials have enough information to let the providers understand and comply with the content. And then there's a process set out if there is a new policy or manual or a change to an existing policy or manual. If you want me to go through this in detail, but it's kind of all about providing notice that there's been a change, giving an opportunity to respond, object. So, section 6, prior authorization. So section 6 and 7 are some impact reports to measure how what impact this bill has had. In the first case, it's on insurers. This would require by January 15th of 2027, each health insurer with at least 2,000 covered lives in Vermont, so more major, not the that's.
But these impact the ERISA.
No, we can't.
No, so this is basically Blue Cross Blue Shield MVP that are two.
I believe Cigna also
The
has,
Cigna does, I know Cigna does Blue Cross, not Blue Cross, Medicare. So.
right, this is not, I don't believe this applies to Medicare.
No, I think you can, but I know Cigna does like.
So this has health insurance, basically your larger Vermont health insurers, report to certain committees, including this committee, on the impact of the prior authorization provisions of this act on certain things during plan years 2025 and 2026, on utilization of healthcare services covered by the plans, on the development of the insurer's premium rates for future plan years, and on the insurer's estimated avoided costs, including how they determine the amount of savings from avoided costs, the costs of alternative services and procedures that were ordered for insurers as a result of a denial of a request for prior authorization. And the costs of emergency departments and inpatient stays as a result of denials of requests for prior authorizations. So that's having the insurers measure the impact of the prior authorization provisions.
Okay, but what we're,
Right.
the implications I've heard is that this could cause a substantial increase in health insurance costs. So we're going to let health insurance rise, which will cause some people to not be able to afford it or to not be able to afford, they'll go to a bronze rather than a platinum. And then we say, oh, it's raised too much and we're gonna take it back out and cause the insurance to go down.
I think what the impact is going to be depends on who you ask. I know you have a report from
everybody.
House Healthcare, so I will let her speak to some of that as well.
Okay.
Section 7 is the provider impact reports. And this is requesting that organizations representing various healthcare providers, so hospital employee, FQHC employee, and independent healthcare providers affected by the prior authorization provisions of the Act, request that they gather information from their members twice, once on or before January 1st, 2025, before these provisions start, and once on or before July 1st, 2026, 18 months later, regarding current circumstances and the impact of the prior authorization provisions of this Act on their provider members and the members' practices. And it says, to the extent possible, align with some nationally recognized provider organizations and include information on the impact on care delivery, quality of care, and staffing. And then on or before January 15th, 2027, the provider organizations would report the information that they have summarized, so that you're able to look at the information from the insurers and from the providers at the same time. Section 8 is repealing that claims edit working group on January 1st, 2028. And then finally we get to the effective dates. So the insurer impact reports and provider impact reports and effective dates take effect on passage. The changes to the prior authorization timeframes take effect on January 1st, 2025, with a carve out for plans that have to make changes to their technology because they do their own internal utilization review process. They would get an extra year if needed to come into compliance. And everything else takes effect on January 1st, 2025, and applies to plans issued on and after that date, to all healthcare provider contracts entered into or renewed on and after that date, and all claims processed on and after.
I think that's all we need.
Okay.
Any questions for Jen at this point? Senator McDonald.
So if a pharmacy benefit manager manages to secure a better yield from it.
This is not pharmacy benefit. I mean, in most cases, occasionally there is a pharmacy benefit. And it's just steps in steps.
That was therapy.
Where does the money go?
I'm not sure. I either didn't hear or didn't understand the question.
That makes two of us.
Okay. I don't think anything with pharmacy benefit managers are in this bill. That is a separate issue.
There is a description of the fact that it may be a PBM that has step therapy protocols as part of the pharmacy benefit, but that's more an administrative description.
Okay. We can look at them. We have that pharmaceutical prices in here and the rest.
Well, you will be getting, I believe, a bill on pharmacy benefit managers soon because there's fees in it.
Okay. So then we can deal with PBMs. All right, thank you. We are going now to Representative Melissa Black.
Good afternoon, nice to see you again. For the record, Representative Melissa Black. I hope that you will forgive me because I really don't have anything prepared. I kind of got this late yesterday, so I'm not winging it.
Okay. We're just interested in, I think, what problem you're solving and why you think step therapy I think it's really the pre-approval process that has sparked concern, but what was the thinking of the committee when they put this bill together?
So when we put the bill together, I think that it has been very clear for many, many years. And providers, hospitals, any clinician has come to us. And their number one complaint is administrative burden. We have a massive shortage of primary care in this state. And I think one survey I saw, there was like 18% of primary care physicians, I think it was 18%, I could be wrong on that, but it was close to that. Had thought about retiring or severely limiting their number of patient hours in the next year. And when you ask them why, administrative burden. We took testimony from providers who spend upwards of 2 hours every single day jumping through hoops and filling out paperwork, spending hours on hold, just trying to get the best clinical treatment that they know their patient needs, just trying to get the payer to approve these things. You can spend hours waiting on hold. The last level of appeal for a prior authorization is called a peer-to-peer. It's where the provider can call the payer, and that payer is supposed to have a doctor, usually not of the same specialty, somebody who's sort of following protocol, and that doctor can talk to that doctor and explain why they need this approved. You can spend hours waiting on hold for a peer-to-peer. It's like when the cable guy says, we'll be there between 10 and 2, that's what scheduling something
How
like
often does that kind of hours unfold?
this. Well,
Weekly,
we could-
monthly, twice a week?
we could call a payer right now from this room and it will tell you how long the
No,
anticipated.
in
hold time.
every day,
Every
there is
day.
a pre-approval requirement that takes several hours.
For providers that testify in front of us, they said they spend upwards of close to 2 hours a day. Certain providers. Most
What?
have staff do this for them,
That's what I was thinking.
and
That's what you did.
massive amounts of staff.
Isn't that what?
Well, I haven't done, I will say that I thankfully.
Yeah. But
I have not done it in many years,
Right,
however,
but-
I supervised a staff.
staff that does it, okay,
Yeah,
so it's
and-
not generally the provider unless you're in a real.
It's not generally the provider, although it has actually gotten to the point now where it's nursing staff. So that is clinical staff. That is a nurse who should be in direct patient care, and they are spending their time on the phone, on hold. Going through, most payers at this point use a third-party vendor that you go onto an online website and you do prior auth on a computer, and just entering that data into that. I mean, if you get really good at it, you can probably do a prior auth in about 20 minutes. But you have to think
Is
about,
that just
that's every patient that you're doing now.
every person that needs a treatment? And you've said that's every day? You
Every
have
day.
Every day.
Every day.
And is this just our public insurance, or are you dealing with ERISA companies? Do they, so
They
they
do.
also have.
They
funds.
also.
And so this, you know what breakdown that is? Because if all our big companies are excluded, anyone that's self-insured.
Mhm.
That's probably a good portion of Chittenden County, because that's where the big employers cluster. I'm just wondering, how much of a burden are we going to relieve?
Well, so a lot of what H 766 does is it doesn't necessarily even, I mean, there are certain pieces in it that remove and set expectations, but what it really does is it aligns. So right now, what happens is, I mean, imagine this, you have maybe, I'm gonna say 8 payers that you deal with on a regular basis. Some of them are ERISA, some of them are, qualified health plans, Medicaid, Medicare. So you've got this bucket and say 8 to 10 different payers. Every single payer has different rules for all of these procedures. So you now have to know the rules for every service you might want to provide, every prescription that you want to order. You're going to have to figure out what this payer requires. Does this payer require prior auth on this head CT, but this one doesn't? What does this payer, when they do have a prior authorization for a head CT, what do they want to see?
So
And they're all
you've-
different.
Okay, so you've got all different ones. This.
So it becomes a guessing game, I guess is what I'm trying to say.
I'm assuming
Yeah.
that you know what you're doing. This would, you're aligning with Medicaid.
So we align in this bill, there are, the prior authorizations align with Medicaid. And the reason for that is Medicare actually doesn't have prior authorization. So if you think about all the payers in Vermont,
Right.
and I'm trying to see the big pie chart that Nolan always puts
But
up for us.
Medicare also has a very limited scope of service. That's why we all have to have Medicare supplements.
No, Medicare does not have a limited scope of services.
It does hospitals.
They have hospitals, they have Part B, which is,
Well, part B, I
Medication.
have to buy.
yes, you have to buy it.
Okay, so
But they still cover
Medicare as an entity has a much more limited scope of service. It doesn't cover like the Warren nursing homes. It's more limited. If I didn't buy Part B, I would have a very large medical debt at this point. Just because Medicare doesn't cover outpatient.
So there are sections in this bill, I believe when Jen walked you through, well, particularly around claims editing, which does follow the rules of Medicare to align with Medicare. There are certain, there's like an A, B, C, or 1, 2, 3, 4, I can't remember if it was A, B, C, D. Where for each of those types of services, it says how you will align with Medicare. So for Part A, there's, which covers hospitalization, that's hospital, there's, I think that's B, maybe.
So, Jen Garvey again, so we have outpatient and professional services,
Yeah, so that would be Part B.
Part B, but potentially also some, because there's facility claims is Medicare code editor, that may be
Yeah.
just the facility piece, whereas the professional services in the hospital, I think would fall under the
Part A,
Part A.
no,
Anyway,
professional services in the hospital fall under Part B. Hospital falls under Part A, facility charges.
facility.
So that's the Medicare code editor. And then there are exemptions for any other type of service that you would have, which would be your Part D, drugs.
It was done in, I think, 68, and it met the needs of 1968, when your doctor frequently took payments in chickens, and your big cost was hospital.
Well, if we wanna talk about aligning, and if we're
Okay.
talking right
I
now
think
with
we've got
aligning
that
with
you're
Medicare
aligning with Medicare
for claims
for claims
edits.
editing.
And Medicare has very exacting standards on
Yeah.
claims edits. They put them out quarterly, they tell you exactly what they're going to be. So that's why we have that aligned. So prior approvals, we have aligned to Medicaid. So when you start looking at that pie chart, you have Medicare that doesn't have prior approvals. You have Medicaid, which is another quarter, so and right there, Medicare and Medicaid, you have half of your population.
Right. But Medicare paid is a government welfare program. It is not an insurance company.
I would
So
call it a benefit.
it is, yes, it is a benefit, but it is not an insurance company. And if it falls short, we get called upon to bill it out. I don't know if it's an insurance company, they're not exactly the same in their purpose or their government, their financing structure.
I would say that Vermont Medicaid has a responsibility to be fiscally responsible.
Oh, yes,
We took testimony from DEPA. And, you know, one of the things that happened during the pandemic was they lifted the prior approval process. They did not want to restrict services, so they just said, you know what, we're gonna stop prior approval. What happened was they found out that utilization didn't actually increase at all. And that they've been going through this process for all these years.
utilization of those services.
Utilization of those services, they then put back in prior approval
But that could be any service, right?
and service.
They just didn't wanna gum up the phone, so there was very limited prior authorization, regardless if it was for.
Yeah, everybody was
COVID,
working
yeah.
remote, so you
Yeah,
couldn't.
it was for everything.
Right.
For everything. And so they have put back in, they put together a committee, which meets, I think, quarterly, maybe monthly, I'm not sure. And they go through services and they look at utilization to see, you know, where utilization is. They compare it, cause if you're an attributed life, through one care, you actually don't. That doesn't require prior approval, so they've compared, patients that are attributed to non-attributed to see if utilization is different between those two populations. And for services, you know, high dollar services, there is a massive list of for surgeries and procedures that have medical risk to them. They require prior approval on those. But in general, they pretty much eliminated a lot of the services that they used to require it on because they found people weren't abusing it. And that they have been going through all this process and the administrative burden for them to, you know, go do all of these things. They reutilize those people in other areas in Viva. And so, again, when we go back to that pie, and then we start putting in qualified health plans. Now you're talking about a lot of people. You're talking about 75%, maybe, I'm gonna go 70. Picture the pie in my head. That's when you start getting real alignment. And that's when providers are working under the same set of rules and they know what to expect. And they know the rules of the game. And that's when administrative burden comes down. And then there are various provisions within the bill that, you know, I mean, if you want to talk about step therapy, so do we all understand what step therapy is?
I think
For like
essentially-
ALS.
Well, it's where
With the least-
you start with the least and you have to move through various treatments. Or
this is
medication
Shouldn't get them.
before you can get to a
$3,000 pill.
yeah,
Okay.
exactly. So this bill does nothing to eliminate step therapy. All the rules are still in play. The only thing is that in the provider's clinical judgment for real clinical reasons, and they have to justify, the provider can override. The provider can say, I'm not going to prescribe these 5 medications that are on your tier 1 because I know that I need to get this patient for this condition with these, co-occurring conditions. I know that this is the best treatment and that they are going to fail on these other ones. I consider it, you think about the Hippocratic Oath. First, do no harm. What step therapy essentially is harm your patient first before you can then do no harm. And all this bill does is it basically says in the provider's clinical judgment, this is why this person needs that treatment, and the payers need to abide by that. They will tell you now that they do have those exceptions. We took testimony from many providers who said, I have gone over and over and over again and said, I need to keep this person on this drug. And the payers have said, sorry, back here. There are some sections in here where if you're on a chronic medication and you've been on that medication for say 10 years and you're stable on it, and it's working for you, if it is a drug that requires prior approval, every single year, once a year, that thing has to be prior approved again and again and again. This puts a little guardrail on it where if you're stable on a drug, then it's only every 5 years that you have to go through that prior approval process. It makes some tweaks around if you change plans or pharmacy benefit managers at the beginning of it, say you get a new insurance within the new year, instead of having days to get a prior approval, you have up to 90 days. And the reason that's there is if you think about it, if any medications you're probably on, you get 90-day prescriptions. And so you could actually be on a new plan for months before you ever go to get your refill of your prescription to find out that, oh no, it needs a prior approval. And now you've gone off of your medication because you can't get it because you gotta go through the prior approval process. So it just does things like that. Again, what the bill is really trying to do is it's trying to align as many payers as possible. And I will say with the ERISA plans, that oftentimes, eventually, they end up following the rules that everybody else is following.
Okay.
Just really quick, so a lot of this is new to me and I'm trying to understand what for the prior authorizations will still be required. This is contemplating that for urgent 24 hours, they have to approve or deny, or else it's considered granted, and for non-urgent 2 business days, otherwise it's considered granted. How does that compare to the current state? Do they have that tight a time frame?
48 hours is what they have currently for urgent.
Okay.
So think about urgent. 48 hours.
I have an experience with
Oh.
that. My daughter, who since passed on, went into a cardio, this was in the midst of COVID. I spent many hours sitting in parking lots. So she could go in. They took a liter, or it might even be 2 liters of fluid out of her lungs. And they were very concerned that she had blood clots in her lungs. It was 5 o'clock on Friday afternoon. I believe she had had a CAT scan within a month or 2 looking at cancer. The doctor said, we'll deal with it. Just go. And I believe if you go in through the emergency room, you can get it. So you're not shut out. If you go through an emergency room, they do what they need to do. So it isn't like if you are in an emergency situation, you can't get that care. There is a backdoor.
Madam Chair, you are going to hear, you're going to hear a lot of numbers thrown at you. And, we've asked questions on all these numbers. but the exact circumstance that you had with your daughter happens every single day. And when you ask payers and they say, this is how much it will cost, what they're doing is they're calculating their denials and what the service would have cost. Can you please tell us how many emergency room visits have you had where a test has been ordered that required prior approval if it wasn't done from the emergency department? And how much did those emergency room visits cost? And the answer is, we don't know. That circumstance with your daughter, I can tell you from someone who worked in primary care, that happened every single day. Every day, somebody came in, just like you're supposed to do. You're supposed to go to your primary care physician. That's how we save money in the system. And your provider looks at you and says, you need a CT. You need this test. I think this is what your diagnosis is. It goes through all the differential diagnoses, but I can't be sure unless I have this. But if it is this, you need it and you need it now, and we need to find that out now. It cannot wait 48 hours. And it certainly, sometimes you can't wait 24 hours. So what you do is you say, I need you to go to the emergency room, because the emergency room is exempted from prior approvals. So we have people who do not need to be in our ERs, only because they are there because they can get the test that nobody else can get without going through a prior approval process. And I mean, listening to providers talk about not being able to get inhalers, pediatricians not being able to get inhalers for kids because there is no appropriate one on the formulary. And kids ending up in the emergency room having to do nebulizer treatments because of asthma exacerbations. These are all costs that never get tallied into the whole, this is how much this is gonna cost us.
I'm gonna have to wrap this up because I've got a bunch of witnesses and
Absolutely.
we're gonna be hearing from providers.
Absolutely. Thanks for having me in.
Everybody.
I'll see if they come around, but I have no committee this afternoon.
Not there.
You got some good, Mine's from Mark Peluso,
Okay.
the chief medical officer at Middlebury College.
Okay.
He sent slides that he shared with the care board about physician burnout, the hidden costs and prior
Mhm.
authorization. That's what I was looking at while you were talking. It's a good, I think he sent it to both.
Okay. Next, we have Nancy Hogue.
Oh, do you wanna go next time, or do you wanna have Andrew go so you
I
can
can
breathe?
go. Yeah.
Yeah, sure.
Nancy, do you want to catch your breath and then go to Andrew?
That work? All right. Well, actually, don't talk to you all at the same time anymore, but do my best.
Okay.
Good afternoon. My name is Andrew Garland. I'm a resident of Montpelier. I work out of King Cross, Blue Shield, Vermont. I'm the Vice President for Client Relations and External Affairs. I've been in that position for about 10 years. I've been in the industry since 1998. For much of that time, I've worked in the provider space. I was the Director of Provider Contracting for Blue Cross. I was the Corporate Director for Provider Network and Provider Affairs. And I worked briefly for MVP Healthcare for about 3 years as the Vice President of Enterprise Network Strategy and Payment Reform. Actually, I believe I testified for some of you a long time ago in that role. Yeah. Also, I just want to say I participated in several legislative work groups, ordered by the legislature on the Fair Contracting Standards Act, and also on a previous claims editing standard work group that was spearheaded by Paul Harrington of WAS. And I'll talk a little bit about that in a minute. The theme for my talk today is big claims require big evidence.
And I'm going to start this off by saying that this committee knows very well the economic challenges that our friends and neighbors are facing in Vermont. It is daunting. Affordability is on everyone's mind. Housing, groceries, taxes for education, infrastructure costs, and healthcare, which is a huge line item on everybody's budget. And it's with that in mind, I want to make an ask of the committee. And the ask, you probably saw, if you read the Digger article where I was quoted earlier this week, it's the same ask. Please be deliberate and fully informed about what you are being asked to consider. When it comes to the cost of healthcare, there is no margin for error. We do not have enough money in our little state to fund the healthcare that is needed. That is a fact. And members pay not only cost share, but they also pay premium. And when they can't afford those things, they don't get care. And that has serious consequences for the health of our friends and neighbors too. If they can't afford the care, they don't get it. So affordability has to be a part of our thinking as we approach these issues.
No.
I'm gonna talk a little.
Yes. We will have an floor amendment for the captive insurance bill.
Thank you.
I'm gonna talk a little bit more about this in a minute, but our commercially insured employers and members bear an outsized portion of the healthcare costs in Vermont. And they are struggling to continue to carry that burden. We talked a little bit ago about Medicaid and Medicare, and I think it's very important to keep in mind the payment amounts that come from those payers are very, very different. The Green Mountain Care Board, Zane, if you wouldn't mind, please showing the first slide. Green Mountain Care Board gave a presentation just last week in House Healthcare that shows how premiums in the healthcare exchange have risen by an average of 53% in 4 years. 53% in 4 years. What else on your budget is moving like that? And this is a huge part of your budget. These are unbelievable costs for Vermont families and businesses. And I have to ask the question, is this time to throw open the floodgates and wash away cost controls that very responsible non-for-profit health plans have been building for years? Yeah.
I mean, I just wanna make sure we're comparing apples to apples, and what I heard is driving the increased cost of healthcare is pharmaceuticals and ER visits.
Many things are driving the cost.
Okay, I heard those are far and away the biggest. Do you have another major cost driver?
Well, specialty pharmaceuticals
Mhm.
are particularly driving costs, and I think Nancy could talk more about that.
Mhm.
We are very aware and informed about how emergency rooms are used and where avoidable cost is. Vermont has always had an avoidable emergency room problem, and that's because we don't have a lot of hospitals and we don't have a lot of providers who are able to stay open in evenings and weekends. So we always have an emergency room problem. That's not really new. But if you look at the Green Mountain Care Board's materials, you can see just the spike in the cost of hospitalizations across our state. That's driving a huge part of what's happening here.
When we first started trying to control costs, the lack of health insurance, i.e. the lack of regular care, was causing people to use the emergency room as their primary care, and that's where you took the kid at 10 o'clock at night with the hearing. And I know we've worked to get that down. It would be interesting to see, is that up now? I know we've had an awful lot of mental health issues going into the emergency room. But it'd be interesting, I know we have those statistics to find out how many other people are using it for regular health care.
I believe that it must be up because the qualified health plan pool has shrunk so dramatically. And we can explain some of that with Medicaid redetermination, but not all of it. So where are those people getting care? And even in the large client space that I work in very often, we now have banner Vermont accounts walking away from their group health plan and sending folks out with a small allowance to buy an ICHRA. That shirt is on. Across the
There are small groups,
some large too.
some large,
Yeah.
right? They usually Because I know the small group has been in and out. And it's, yeah, the employer can give you $50 a month and say, go
That's
buy
right,
what you can
that's right.
and not providing, so we need to get those numbers in here, all right.
Yes, absolutely. So I really want us to ask, can Vermonters afford to experiment with untested policies that frankly are not being tried anywhere else in the country? Such as aligning, commercial edits with or commercial prior approval with Medicaid prior approval. This is a big experiment, and I wouldn't say that we can't consider these things or that we shouldn't, but big changes, big claims should be supported by big evidence, and I just am not seeing the evidence. But I have some for you. I'm gonna present just a few numbers. First, actually, if you go to the second slide, Zadie, we're already leading the nation, but not in a way that I think we want to be. Our healthcare trends are far outpacing the national average. Passing this bill will increase this delta. That is unquestionable. Now, let's talk a little bit about claims edits, what they are and what they do. The bill contemplates that Blue Cross and other payers would be held back from doing many of the claims edits that we do. These are checks, corrections, this is billing analysis, right? A basic financial control to find out if the bill is accurate. We have a financial obligation, we're fiduciaries, right? We have a financial obligation to our members and our clients to review the almost $1.5 billion that we are billed. If we just paid those claims without looking at the bills and ensuring that they were accurate, that would be grossly irresponsible. Claims edits identify errors, overcharges, and occasionally fraud, waste, or abuse. Usually they're errors and overcharges.
Can I ask, do you have a sense of what happened around 2001 that created the gap?
I sure do, but that's a really long conversation and probably not related to this bill.
So it's not related to the bill.
Not related.
I mean, when I look at this, I see an older, whiter state in Vermont than the average US state. And to me, that has to play a role. I mean, I'm concerned about the cost of healthcare,
Yeah,
but we want to make sure we're making smart decisions about what is driving it.
yes.
So it doesn't help me necessarily to look at this graph and say, oh my gosh,
Well, to me, the graph
that's the
said
answer.
we have to be careful that we're not making it worse. And that's really what I'm asking you to think about.
Our population is our population. We are older, it'd be interesting to look at Maine. We also have fairly low, at least we did, it probably is creeping up, number of uninsured. Other states, really, we have expanded Medicaid, so we are insuring more people than other states.
Right, there's states we don't want to be like, that are below this
I do
average.
not want to
so-
be Louisiana. Sarah, did you have a?
Just a quick thing I would say, Sarah Teach out with Blue Cross and Blue Shield of Vermont. These are just a couple slides from a really comprehensive slide deck from the Green Mountain Care Board that they go into all those New England state
Okay.
comparisons and they look at a lot of.
I'm happy to have that.
So
Yeah.
I think it's really important. You're asking great questions,
Yes.
but
Okay.
we didn't plan on giving that presentation.
We can read it. Second Brock.
Are the numbers adjusted for inflation annually?
I'm quite sure that they are, but this is not my data, so I don't want to go on record
Well,
with
I wonder
that.
if we could, if we could look at if you have the underlying data. to look
Absolutely,
at, and
yep.
That way we can tell whether it's inflation adjusted.
Yep, we can do
I
that.
it should indicate whether it is or not,
Yes.
because that would be very meaningful in terms of the trends. If they're inflation adjusted,
Yes.
they would be very different than what the graph indicates.
Well, as Sarah says, the Green Mountain Care Board prepared 30 or 40 slides on this matter, and frankly, every cut says that Vermont is in a lot more trouble than it realizes. We're not doing as well as we think we are, but if we look at how old we are compared to other old states, we are spending a ton of money and we're not getting as much value.
Okay.
So just back to claims.
That report would be on their website, so
Yes.
anybody that wants can get all 30 slides.
Yes.
So we'll take a look at that.
So a quick example of how a claims edit works. You go to a restaurant, you order a fixed price meal, it's supposed to come with the salad, the entree, and the dessert. You get the bill, you're billed for the fixed price meal, but there's also a charge on there for the salad and another charge for the dessert. What do? You raise your hand and say, this is a mistake. It's all included in the fixed price, take off the salad in the bill, right? That's what every good Vermonter, right? We read our bills and we make sure that they're accurate. That's what claims edits do. All the claims edits that we use are developed by CMS, by the American Medical Association, or by a provider specialty society. So we are reading back to providers their own billing rules in our claims edit to make sure that.
So
they're followed.
what would this bill would change to what?
So this bill would have us align our claims edits only with the claims edits that Medicare uses. But by only following Medicare, we would be missing a huge swath of the services that we provide, as you were all talking about a few moments ago. Medicare focuses on a very different population. That means that they don't pay for pediatric services, they don't pay for OBGYN, they don't focus on licensed alcohol and drug counselors, they should, they don't. They don't focus on naturopaths or psychologists. I have a long list of things that we reimburse that Medicare simply does not get into. And Medicare does apply edits. They have NCCI edits that they developed.
But Medicare has a limited scope.
They do.
Does this include Medicare Part B, which includes
It does.
the rest? That's done by private insurance companies, right?
And sometimes, but Medicare also does Medicare Part B direct for many people.
Okay.
Yes.
And are those edits included?
I think, yes, the NCCI edits are developed for Medicare.
Okay.
Unless something has changed, Medicare uses those edits to make sure that their payments are accurate. So I think Representative Black was just a little bit off there. I mentioned earlier too that I was on the claims edit work group that Paul Harrington convened after a very similar conversation with the legislature. And we went through every NCCI edit with Paul and a group of provider representatives. And the provider representatives in the room said, well, actually, we don't want that one. That will hurt us. We don't want that one. That doesn't make any sense. And ultimately, they concluded that what we concluded, some of these NCCI edits are right for a commercial population, but many of them are not. Aligning with Medicare, it's a nice concept and we should push on it, but it can never be perfect because Medicare has a very different approach to what they do.
Know how you edit for pediatric or OB/GYN care if Medicare doesn't cover that.
Yes, we use edits that are developed by the AMA or it would be edits developed by the American Academy of Pediatricians, for
Okay, but
example.
if we put this bill through and you have to align with Medicare and Medicare doesn't have that
That's right.
standard, then you're kind of in limbo.
That's right. Then we would have to work on some sort of process to try to get exception to bring
Right,
those
you-
edits to bear.
Okay, but you already have nationally approved AMA. Paul Harrington was the head of the medical society.
That's right.
Remember that time.
That's right. So,
Can I ask a
Yeah.
question? So I'm trying to understand claims edits, this is a new world to me, so who established the standards for these claims edits? Is it a standard across different states and are we doing it, are you doing it in Vermont or is DFR established?
So essentially, all of the medical billing and editing standards derive either from CMS or from the American Medical Association. Those two bodies really are responsible for publishing all the code sets that we use to pass
You
information
have
back
the
and forth.
providers and the regulators.
That's right,
Okay.
that's right. We do not make up edits. They all come from CMS, from the American Medical Association, and in some cases, specialty societies. So the American College of Orthopedics might develop a set of billing guidelines around a bundled hip surgery, for example, right? That says, well, in this circumstance, the anesthesia is included in this code, so don't bill it separately, right? So these guidelines are not, they don't come from the insurance sector, they come generally from CMS, from the providers.
CMS is Center for Medicaid.
Yes.
Medicare, Medicaid service.
Just so I understand, what you're talking about now isn't directly related to prior authorization.
That's right.
It's a separate, can someone tell me where this page is?
Section 1.
Section 2.
I think
Nothing.
it's-
You have to get through all the oral ones
Yeah.
first.
I know.
The first section is on step therapy, and then you're gonna go into editing.
Section.
No, it's section 2, prior auth starts on
Has
27.
an effect for Medicare.
Yeah.
Yeah, that's it.
Okay.
Okay.
Okay, yep, that is page 20.
So are you, I mean, my brain works in terms of like, what are you asking for? I mean, I know you're asking for this section to be gone, but is there, if the problem is that there are areas of medicine that are not contemplated here,
That's right, you would not be able to edit them.
so, but what language would you need to be able to make your own decisions?
Yeah, I think we did have suggested language, which Sarah can send around to you.
Okay.
Yeah, essentially, but I would ask that we be allowed to use any nationally recognized edit that
Which
comes
you do
from,
now.
right, exactly, that comes from CMS or AMA or a national specialty
I
society.
think the problem I heard was for professionals, you have one editing standard
That's right.
and all the ERISA people, so all those other unknown insurance agencies that are writing contracts with self-insured,
Yes.
they have different standards. And Medicare has a standard and Medicaid has a standard.
That's right.
And so they're trying to get some consistency. They're saying we're all gonna go to Medicare. But Medicare doesn't have editing standards for the services they don't provide, which Medicare is,
Right.
when it was written, was for hospital care. And you had to go from the hospital to the nursing home, and it's very limited coverage there. It was written for 1968, when you had a heart attack, you went to the hospital and you died. And the life expectancy was 67, something like that. And that's not the life expectancy, and people frequently spend more times in other facilities that are not covered. And
Yes.
so that's.
Yeah, it's true that different payers will bring different edits to the market depending on what they think might be being misbilled. Whatever, it takes money to do this, so we can't look at everything all the time. We do as much as we can, but the billing standards are not different, right? The codes are developed by AMA and CMS, and the billing guidelines are not different. So if claims are being billed correctly, the edit standards really shouldn't matter. It's only when they're being billed miscorrectly that the edit comes in and changes a bill, right? And says, no, this is not allowed by the rules. We can't pay this way. So it's true, there are different edit approaches, but the rules are the same.
Right,
Right.
but for the
Everybody.
doctor's office who gets an edit because it wasn't coded correctly, that is an annoyance.
It
It's time, it delays the time they get paid.
Yes.
Can I assume that there are some offices that do a better job than others?
Absolutely. And actually, it doesn't really delay the time that they get paid. We make the edit in real time and we send the claim out. We're very efficient at this. It's built right
Pay
into
them for the editing claim,
We do.
not.
So there's no appeal or,
Oh, sure. Oh, yeah. Provider can call us and say, you messed up. Here's what you didn't understand. Absolutely.
so that takes longer. I mean, you're paying them what you believe you owe them.
That's, well, we're
On
paying them what the coding standards say
Uh-huh.
we owe them. And if they have a disagreement, we'll absolutely listen. There are not many appeals on claims edits.
Okay.
That's not common.
So,
Prior approval maybe is a different story, but there are not many appeals on claims edits.
and I think for this committee, there's the healthcare committee that would like the best. This committee, and we haven't done much. In the old days, we did quite a bit with pharmacy benefit managers, and we may get back there. But that was before Obamacare. And we spent a lot of time trying to get Vermonters insured. We did Catamount Care, which really was expanded Medicaid before there was such a thing. All trying to get people insured at a rate they could afford. So that they didn't end up in the emergency room.
Mhm.
If they go to the emergency room and they don't have money and they don't have insurance, the cost gets spread out onto all of our insurance. That, it's just cost. And that was raising our rates.
Right.
Our rates are still going up.
Yes, they are.
These are some of the ways insurance companies are working to keep the rates down.
But I think part of our job is to weigh costs that then go to the emergency room. And so as I understand claims edits, you don't make claims edits on emergency room visits.
That's right, or urgent care visits.
I mean, I think a lot of us are also experiencing that we are told to go to the urgent care and the emergency room more and more.
But that's probably appropriate. I mean, if you can't wait 2 days for a prior approval, it doesn't have anything to do with this prior approval. Now, if you can't wait for 2 days for a prior approval, and your physician feels like, I don't wanna wait 2 days, I'm gonna send you to the emergency room, my response would be good. Get them to the emergency room and make sure that this is okay. That emergency room use is very important in circumstances like that. We are more concerned about avoidable emergency room use. And that's when your primary care physician really could have provided the care, and they just didn't have the time to see you, or you didn't bother to go to them because you didn't know that they could, but.
Primary care is only in 4 days a week. And they used to book like a couple hours at the end of the day for the kid with the strep throat or the earache. They don't do that anymore.
Yes.
They send you to Express Care around here and they handle those basic, I need 3 stitches because I cut my hand with a mandolin. If you took your thumb off, they send you to the emergency room, but if it's a cut, they'll stitch it. They'll do the things that you used to go to your doctor to do. And so.
Which is more expensive, right?
Which is, and there's just a new delivery system that has been evolving. You used to get to sit in the waiting room at Express Care. But because of the violence, even though COVID has gone, the potential for violence in medical facilities, you now have to sit in your car. And you are escorted in to a treatment room at the Express Care. And violence in the hospitals is very real.
It is.
And is taking a toll. People don't want to work in the emergency room anymore.
That's very understandable, and I know you're all in a very tight time frame, so I'm just gonna switch gears and speak very quickly about prior authorization. This bill mandates that we match Medicaid's prior approval program, the prior authorization program, that's the gist of the bill. What I wanna just say, you talked a little bit about the cost shift, the cost difference between government pay and commercial pay. I wanna give you some examples, because I think you're gonna see that the cost variance between Medicaid and commercial makes prior approval a very different game. So let me give you an example of an MRI of the brainstem. Okay, Blue Cross Blue Shield of Vermont pays on average about $4,400 for that service. Medicaid pays $283. For that same MRI. We pay $4,400, they pay $283. For a sleep study, Blue Cross pays on average $6,836. Medicaid pays $565.78.
But those rates aren't being harmonized, just that you have to.
That's right, I'm
pay
just
for the
telling you
same
that,
thing without
right,
price.
this is just the difference in
Big
rates.
difference in
Right.
rates.
For treatment of a varicose vein, Blue Cross pays $19,625 on average, Medicaid pays $905. So prior approval is much less important to Medicaid than it is to a commercial payer. Our members are cross-subsidizing care for Medicaid members and Medicare members. And I'm gonna just go back to where I started. They cannot bear the burden any longer. It is so expensive for people who are trying to afford commercial healthcare. And we are desperate to find cost savings measures to keep people covered and to make sure that they are using their benefits and getting care, right? If they can't afford the care, we're all failing. So again, my ask is just have the data on what's being proposed here and insist on it before we make these sweeping changes. And say, can you show slide 3? I just have one more example on this. So Blue Cross in 2022 paid in aggregate $56.5 million for advanced imaging. And we redirected about $6 million in that care through the prior auth program, and much of that is redirected. People think of these as denials, but typically what happens in this space is the provider says, well, we want to have a we want to have a CAT scan, which is about $1,000, and we say, no, actually, do that MRI. It's $4,500, but that's the right test. The CAT scan will not give you the answer you're looking for, and then we'll have to do the MRI on top of that. So we'll spend an extra $1,000 on an unnecessary CAT scan. Prior approval is not all about denials. There are denials, but the denial rates are very low. A lot of this is about redirecting to the right therapy. And if there's a problem, doctors are not agreeing with each other, we get on the phone with them and talk about it. Medicaid spent $5.4 million in total on advanced imaging that year. So we saved more through the prior approval program than they saved in total. These programs are really important to commercial in a way that they simply aren't to Medicaid. And a few other just interesting points, but we did a quick review. Vermont Medicaid doesn't have corresponding billing codes for 327 of the codes for which we require prior authorization. They just don't exist in the Medicaid system, those 327 codes. So they don't matter to Medicaid. Medicaid doesn't notice those services.
That's mostly pediatrics and OB/GYN and other things.
No, Medicaid.
Well, this is Medicaid.
Oh, Medicaid, okay, then
It's
what's,
just stuff that they're not able to pay for, they don't cover. We can get you the detail.
okay.
Yeah, I don't have it at the top of my head. Let's see, there's 310 codes that they require a proper prior auth for that we don't. We don't prior auth those codes at Blue Cross because we don't have an issue with those services being billed or prescribed improperly. So Medicaid, Medicare, it's important to align where we can, but they're very different. So let me just get to the end here. I'm gonna read a little because I put some energy into this. The committee knows the financial challenges and limitations for our citizens. We all get it. These numbers that we're talking about are almost incomprehensible when we start to think about the increases that people are being asked to bear. Some people have said you should.
Driver in your property tax
Yes.
increase, 16.4%.
Some people have said you shouldn't believe our estimates. I'm telling you that this is north of $50 million. We're looking at 5 to 7% increase in premium from this bill as written. If you want to dive deep into those numbers, we will sit down with any member of this committee, with the experts from Blue Cross, show you the raw data and the math, how the things flow through the system and where that number comes from. It is real. I also want to point out that this legislation will only apply to 2 or 3 Vermont-focused payers, but our providers deal with over 30 payers. All of those out-of-state payers are not going to be impacted by this bill, and we'll continue to have this variation where we're not completely aligned. So to your point earlier about the ASO accounts, the ERISA accounts, this bill would only affect a small number of Vermont commercial members, and frankly, it's mostly the QHP members who can least afford this additional financial burden. Finally, I just gotta sort of wrap where I started. I agree with what you heard from providers about administrative burden. We want to minimize as much as possible the administrative burden on our providers, but we have to remember that we're working in an extremely complicated care system that is not fully funded. We do not have enough money to take care of everybody who needs care. So it is really incumbent on organizations like Blue Cross to follow national standards that are used across the country to fight waste and abuse. Misbilling and wasted care hurts everyone, including providers, because those funds are not available to spend on our poor independent providers who are struggling, right? We're wasting those funds. So before you put your stamp of approval on what you're being asked to consider here, please ask everybody to slow down, put the evidence on the table, and be very clear about how much this is going to cost the system and whether or not you really believe that cost can be borne and is warranted for the improvement that is being put in front of you.
You are saying a 5 to 7% increase from this. That's on top of
That's right.
what we assume will be increased hospital costs and increased pharmaceutical costs, which seem to be drivers. And if you're saying that you've got increased emergency room costs, so this, and it's been said to me, we're fighting an unanimous approval in the House. So we're joining the Appropriations Committee and being the wicked witches in considering whether or not this is worth, doing that balance between, making it easier for people and the providers and making it affordable for, and I'm thinking people on the bronze plan, that have high deductibles and, limited coverage for that. I'm thinking of the small employers, which now can't become an association and move into the big. Every year we do the balance between the small group and the individual group, and right now the feds are keeping up their subsidies and we're able to keep them separated, but that's not going, so. We'll have Diva in and we will have Diva, we'll have them talk about how they go. We talk to Green Mountain Care.
Okay.
And have them in to talk about the trends they're seeing in cost and usage and the impact they're anticipating on health insurance. Yeah,
There's data I was hoping each insurance company could provide that I was waiting for this presentation. I don't know if what. I wanted everyone to share with us the wait time, the average wait time when a provider calls with a prior authorization. To have the call resolved. So I would hope you all are paying attention to those average wait times and getting us that data. Your denial rate, percentage of prior authorizations you deny. If and when a medical professional makes the decision about denying a prior authorization or making a claims edit. Am I understanding correctly? I could have misunderstood this, that prior authorizations were lifted for all payers in the pandemic or just Medicaid? Okay. Did you relax your prior authorizations during the pandemic?
I think we might have for a couple of months, just because everybody was so crazy trying to figure out how to deal with retooling their practices.
yeah, everybody was.
It's so long ago, I forget already.
We also relaxed them during the cybersecurity.
That's right.
That was bigger.
Okay,
Yeah,
so if you could get us some
Yeah,
information
we can
from those periods of time, the kind of data we are looking for about the increased costs that you wanna express to us. And I would like to know from each insurance company how much you pay for your system that besides prior authorizations. I mean, how much are you spending on how much are you spending versus saving?
Yep.
With your prior authorization system? I imagine if you have medical professionals making the decision, it does cost more.
Okay, Senator Gray, you're standing before you sit down. You turn the lights on. And, okay, Senator McCormick has a question.
The comparison between what you folks pay and what Medicare pays is impressive. I mean, you had the impression of this, we were all in for. It's distant enough, the figures are distant enough that I'm wondering are providers who are dealing with Medicare, are they basically providing charity? Or are you being taken for a ride? Because it's wildly different.
yeah. Well, that's a great question. I'm not sure I can fully answer it. I would imagine that those Medicaid reimbursements are probably below cost, at least some of the time or much of the time. In some cases, I believe the health plan, Blue Cross, is also being taken for a ride. That said, And we can draw that conclusion by comparing our reimbursement to what others pay in other parts of the country. That said, when we look at the financial performance of most of the hospitals in Vermont, they're not laughing all the way to the bank. So this is indication to me that there's something kind of fundamentally wrong with our healthcare system that we've got to figure out why we can spend so much more than other states and nobody's making money. And the care isn't really getting particularly better, right? Our life expectancy is not, the Green Mountain Care Board deck is so good, it really lays all this out. Our life expectancy is not keeping up with the rest of the country as it improves. There's a lot of things, we're not seeing quality gains that are sustained, right? Some ups, some downs, it doesn't really get better. So I think the answer is some of both, yeah.
And we know anybody that sat in healthcare, we lost the whole primary, our whole pediatric provision. Any primary care doc that is not affiliated with a large hospital or owned by it, they're struggling. If you're owned by a teaching hospital, you get paid a premium. If most of your patients are on Medicaid, you can't make it. And small rural hospitals nationwide are struggling and they're going down. And you want any kind of chemotherapy in the kingdom, you've got to drive to Dartmouth. That's a long drive in January. So we have an issue. We have a shortage of doctors, of primary care, of pediatricians. We have some major health issues and and the cost is up there. So that's all figured into kind of the state urgency, which we haven't had since we went to the exchange, of keeping healthcare affordable and keeping, I thought we were down to 7% uninsured, but I could be, that's probably changed
I'm
since.
worried about that.
Yeah.
Figure.
Yeah. Yeah, I am too, because the insurance may be great, but if you can't afford it,
That's right.
you're back using the emergency care. Okay. Thank you. Nancy, and I have, our last witness is a hard stop at 4:30. So I may have to do some switching around. If anybody else has a hard stop, let me know. You can, but I'm moving forward.
So for the record, my name is Nancy Hope. I'm a pharmacist and I'm the pharmacy director for Blue Cross Blue Shield Vermont. A lot of you might know me in from my prior role. I was the pharmacy director for Diva Vermont Medicaid for 12 years. So
I know you phone calls.
yeah, many of you are very familiar to me in this. I've been before this before. So anyway, thank you for hearing my comments today. I'm going to be just focused on the pharmacy components of the bill. I'll speak to step therapy and PA. And I'm going to limit my comments. I'm going to make 3 points and give you a little bit of data as well. So I'll try to keep my comments as brief as possible. Thank you. Next slide, please. Oh, I haven't seen these slides. Are you? Sorry.
Nope. Wrong button. There.
There we go. So just very high level, I wanted to show you drug costs and trends this is comparing 22 to 23. So we saw a staggering almost 25% increase in drug spend in 1 year. I've actually never seen a trend this high before in my career, and I've been in this job, this kind of work for 30 years. So it's impressive. 8.6% of that was contributed by increases in utilization, meaning, more prescriptions, more people needing more drugs. But most of it had to do with the cost per prescription. And so 22.1% increase in the average cost per prescription is what we saw year to year. Specialty pharmacy, of course, is a huge contributor to that. So even though specialty pharmacy prescriptions only represent 1.7% of our total prescription volume, a very, very small percent, they represent more than 55% of our cost. So that's where the money is for sure. And the average cost of a specialty drug is $8,045, and that's typically for a 30-day supply. Next slide, please.
Yeah, it'd be interesting to see what that cost might be if you bought it in Canada.
Yes, it was.
Because anybody that wants to go on the Canadian pharmacy online, and you can look up a drug and they'll tell you what they charge you for it. And it's, maybe with these new very specialized drugs, but there's a huge price difference between. And we have a request in to buy through Canada, but the feds haven't granted it yet. We spent a lot of time. Senator Sanders ran buses to Canada. Breast cancer drugs were like 50 to 70% cheaper there. We are paying a lot more than the rest of the world for pharmaceuticals.
That's very true. So let me talk a little bit about our utilization management programs. I wanted to speak particularly to the savings. When we talk about utilization management, we're generally talking about three components: prior authorization, quantity limits, and step therapy. I think PA, you're all familiar with what that is. A quantity limit is when you limit the number of, tablets, capsules, whatever that you can get in a prescription. It prevents waste. It allows for dose consolidation, meaning try to take the fewest pills possible that you need. And then step therapy is when you have to step through a drug to get to another drug. So this is how we, this is partly how prior authorization works. And then we have other drugs where there's no prior authorization, but there is a step in place. And that's usually an automated step, so it doesn't require a provider to do anything, but we would look back in history and see if that drug was there. So the biggest savings, of course, is prior authorization. That this is for 2023, 1 year of savings, and altogether it's almost $39 million. So it is a significant savings that we attribute to these programs. They're very important.
Does this bill do away with prior authorization of drugs?
Not entirely, but there's one provision in the bill that's particularly troublesome, and I'm gonna get to that in a few minutes.
Can I ask, do you must have a medical doctor who's overseeing this program, your step therapy?
Yes, all of the programs that we have, they're all, for most health plans, they're all kind of run the same way. They're overseen by what's called a Pharmacy and Therapeutics Committee. And that's a committee composed of physicians, specialists, physicians and pharmacists. And they generally meet monthly, quarterly, whatever, to review new drug coverage policies. So, for example, for DIVA, that would be the Drug Utilization Review Board. For us, it's the Pharmacy and Therapeutics Committee that our PBM operates. So it's a national committee. But yes, it's all reviewed by experts in the field.
Okay, Senator McCormick.
I need a better understanding of step therapy. So you have to get through one drug before you get to another. Does that just mean that they start with one, and if it doesn't work, you go to the next one? And you don't go to the next one if the first one is working, or that they work together, or?
Right, so if you wanted to get to a, let's say, a specialty drug, we want to be sure that you've tried the first line therapy, right? So the first line therapy might be a a generic drug, or it could be a brand drug, but a traditional, a non-specialty drug. So whatever the sort of clinical guidelines suggest that you try, we want our members to try those drugs first because they tend to be lower in cost. And then if those don't work and you've tried them, then that's perfectly fine. So it's really using drugs in the right order according to the clinical guidelines.
Is the order also affected by likely side effects?
Of course, yep, if you took a drug and you did not react well to it, then we certainly wouldn't ask you to step through a drug that you had a bad reaction to.
Or I'm just thinking that there's blood pressure meds have various side effects, some of which you don't get the side effect below a certain dosage. So you'll go to another drug rather than up the dosage of the first.
I mean, that's really up to your provider, I think, to
That's up to the-
decide,
okay.
yeah,
You don't impose that.
no.
Okay.
I would like to better understand your savings numbers, right? I mean, that is simply derived from denying them a more expensive prescription drug for longer. I mean, when ultimately, for some people, being on a medication that's not working is life-threatening. And sometimes it takes weeks or months to determine that, a side effect is in fact real. Mental illness, it can have a really big impact to taper up and taper down from medications. I would need to know a lot more about claiming savings before I would celebrate it, that's for sure. And are you tracking people who end up in the emergency room because something goes wrong in the step therapy?
Yeah. So we do have a methodology that we can share that
Okay.
outlines how that is calculated, but essentially it's looking at, I'll give you an example of PA. It would look at what was the drug. So if it was denied and there was an alternative drug, typically this is a drug in the same class, has the same effect. We're not typically asking people to choose completely different drugs. But in any given class, maybe for chronic migraine might be a good example. There's, 5, 6 drugs in that class that all basically do the same thing. Some people do better on some than others, but for the most part, they're all, they all are in the same therapeutic class with the same mechanism of action. So, if there is one in that class that is the lowest net cost, then we would want providers to choose that drug. So if a PA was denied because they prescribed a different drug in that class, we would calculate the difference in cost between that denied drug and the preferred drug. And then that would be the savings. We would extrapolate that for a
People
year.
tend to pay a different copay for drugs that are more expensive.
Well, it completely varies by the plan, of course, because everyone has different plan designs, but generally speaking, the formulary is tiered. So we have tier 1, tier 2, tier 3. They would generally pay more for a non-preferred drug, and a non-preferred drug is going to be a more expensive drug for us. So if they move to a preferred drug, it would generally mean a lower cost share for the member.
And this is not unique to you, right? We have spent years doing formularies with Medicaid and the state health insurance plan. This tiering and trying to start at with generic.
Sure.
This has been because it's a major cost driver.
Yeah, I'm just trying to reconcile it with the language of the bill, where I think what it's asking is that a medical professional be able to help someone accelerate or move beyond the step therapy based on their own medical opinion and their observation of the patient. And I'm not sure what costs we're taking into account that they're seeing and referencing of any side effects or the suffering of someone who's not getting the care that they need. And I would tend to want to listen to a medical professional who's observing the person, you know, and weigh that against the cost savings that you're speaking to.
Yep. So first of all, I wanna say, like, we actually do support most of what's in the step
Okay.
therapy
Oh,
section.
okay.
There's only really two aspects of it that I wanted to focus on, which I think, I'm sorry, did you have a question?
Well, on that same thing on methodology, maybe you can answer this afterwards too, but if you prior authorization just denies, but actually just denies for now and then ultimately approves it, are you still counting that as savings in this methodology for these numbers?
No, if it's ultimately approved, it's not included in any savings calculation, and our PAs are all done within 24 hours, so I'll get to that too.
So what one, so we won't focus on the ones you don't disagree with.
Yeah.
What bothers you here?
So if you wanna go to the next slide, it should be next. So this is one, it says, we shall not require failure, including discontinuation. I'm sorry, this is one that we support, so all I'm saying here is that this is very reasonable. We would not expect someone to fail a drug that has no effect on them, or where they've had an adverse effect or a side effect, as you were speaking
I
about
guess,
earlier.
what do you make them prove about this? Because it can take a long time.
We only ask that they attest that the patients tried the medication.
Okay,
Yeah.
It took me 3 days to get violently nauseous on medication that I just didn't disagree. There was no anti-nausea medicine that didn't have side effects, so it's now listed as I'm allergic to.
There we go. Okay, and we also completely agree that as you switch plans, that prior auth should carry over, so that your provider's not having to do it over and over again for the same member. Next slide. Okay, so I'm just gonna highlight the issues. One is when we say that we can't ask a provider to try a drug in the same class or with the same mechanism of action. And so meaning that if they had tried a drug in the same class, that we're asking them to step through, that we couldn't ask them to try, that drug. And the reason I say that I don't think that this is this would increase costs, because much of our step therapy, as I was saying earlier, is drugs in the same class. It doesn't necessarily mean the patient will have a good effect on that drug. So just because a drug is in the same class does not mean that you won't have a beneficial effect from that drug. So that's one area where I feel we should be allowed to, try drugs in the same class.
Application, there's a difference between generic and name brand. Not in the chemical necessary, but in things that are mixed with the.
Yeah. There's some drugs where that's
Sometimes
medically critical, right?
Yeah.
Like thyroid medications, for example, can be very sensitive for generics and brands, so.
Can I ask, does your medical board look at something that's been discontinued and take into account other drugs in that class or with the same mechanism and make decisions to stop supporting those drugs?
I mean, potentially, it depends. So if the FDA allows the drug to remain on the market, right? So obviously, if there's a drug that is removed from the market because it had a very negative side effect, let's say, it doesn't necessarily mean the other drugs in that class are gonna have that same side effect.
But do they ever, when something gets discontinued, does your medical board look at anything else that is similar and discuss the ramifications of keeping it as an option?
Sure, and it would really come down to looking at literature, looking at clinical guidelines. So if that was a particularly egregious, side effect, maybe hepatic cancer, who knows, right? Something really bad happens, we're gonna look at the research for all of those drugs. And the medical societies also are doing that. And so that's how they modify their clinical guidelines. If they think there's a higher risk for this class all of a sudden, they weren't aware of before. So I would say
So it
yes,
doesn't have
that's
to be the
possible.
FDA, it could be the AMA or another
Yes.
organization starts recommending
Yes,
against a certain drug.
exactly. Yep,
Okay,
okay,
so it's the prescription in the same class.
Right.
And you're saying right now, you will try, depending on the situation, you will try the, something in the same class, depending on, if it just didn't lower your blood pressure at all, you might go up to a higher class, but if it made you slightly nauseous, you might try something in the same class that might not have the same
exactly.
effect.
Can I just be clear, this is in the section where a medical professional can make a different decision? Right, it's not saying,
Somewhere in here.
it's not a
there's an
definitive
override.
thing. I'm just trying to make sure I understand.
No,
What-
prescription, it says, it's 3 on page 19.
Okay.
What
Page
is that,
19.
Romanesque 3?
Romanesque
Is it next to Allison?
Okay, so the guiding language is someone can grant an exception.
There's the provider, somewhere in here, the provider can move you up a class. I'm not finding it. Drugs prevention street. Yeah, restoration does. Here it is, it should say. The insured has already tried prescription drugs on the protocol, which has been discontinued due to lack of access. Prescription. I'll think about this. Grant an exception to its therapy protocols upon request of an insured or the insurer's treating healthcare professional under the same time parameters. If this is B, on my thing, it's page 18, but I've got the House bill, which is a strike off ahead of it. So this says that the healthcare provider can grant an exception to the step therapy protocol.
It does say shall grant an exception, so to be fair,
Let's see. I've got not required, including discontinued. I don't see, where is the shall?
it's
Oh, there it is, up at
E1.
the top, shall.
Yeah,
Okay, granted exception to the step therapy protocol upon the request of the insured or the insured's treating.
so I can find the sort of common ground thinking about, okay, an insured is probably gonna wanna get to something faster, they don't actually have medical expertise on what another prescription drug is in the same class, et cetera. Their treating healthcare professional, I would think, does have enough expertise that if they perceived an adverse effect or something that would harm the patient because there was a requirement to try something else that they didn't believe would be in the patient's best interest, that we might want to separate out the insured from the medical professional in this case.
Yeah, and we're not, again, the patients having adverse effects or no effect, that's covered and that's reasonable. This would be, let me try to give you like a more specific example where patients on triptans for migraines, right? For acute migraine, you take what's called a triptan. Sumatriptan is a good example, or zolmitriptan is another example. You can you could step through more than one triptan before you get to, say, a monoclonal antibody like a CGRP.
You're
A more,
speaking Greek, but that's how it's
you know, a more expensive, more specialty like drug. It's reasonable to try more than one triptan because patients can have a different effect to triptans. Some do well on sumatriptan, some do well on thomatriptan, some do well on others. So that's the point. It's like, we just want to be able to have the flexibility to try more than one drug in a class. That's,
This, if, and I wouldn't, necessarily want the insured to be able to do this, but if the doctor, healthcare professional, knows this person has had, everything makes this person nauseous. I mean, every pill is good, has a tendency towards that. And but I think this bill says is, he could say, all right, you can try all 5 of these things on tier 1, but they're all gonna make you sick. So I'm gonna request that, and I think this says he can just say, I'm gonna prescribe tier 2. And I'm not sure how often this happens. But I think that's what it's saying.
Excuse me, Madam Chair, with apologies, Senator McDonald, I
No,
asked to remain.
no. Your chair has not gotten.
Yes, okay, I did not know that.
Checked with me about having half my committee go and your chair's not here.
All right, I did not know that.
Yeah, I didn't know he didn't check with you.
He told me to come, and
He checked with me
I presume
yesterday
he
after
had checked
fact,
with
but
you,
he didn't
I
know
apologize.
anything.
I thought,
Okay, no, you all can go, but that means nobody else can take a bio break in here. Because we still got probably another hour of testimony. And that, so I'll let you
so
check.
this is the scheduled committee. You
I know,
get
he has told me all week and I'm under as much pressure as anyone to get these bills out.
Yeah.
So. And schedule it. All right, so, he goes, I think if you go and take a look at that section 1, because it lets the healthcare professional or the insured ask to be bumped up. Already tried pursuing, this says the health insurance. Not require failure, including discontinuing documents. Insureds who are continuously involved.
Yeah.
Yeah, this takes away, if I'm on some maintenance drug. And I have to come back and get that approved every year, even though I've been on it for 10 years and this takes that away. Is that gonna do?
no, it won't. I don't think this provision would affect that, no.
Okay, grant an exception to its step therapy protocols upon request of an insured or the insured's treating healthcare professional under the same time parameters as set forth for prior authorization. If any of the following conditions concerned, if a prescription drug required from the step therapy is contraindicated or likely will cause an adverse reaction or physical or mental harm. The prescription drug required step therapy protocol is expected to be ineffective based on the insured's known clinical history. The insured has already tried the prescription drug on the protocol or other prescription drugs in the same pharmacological class.
Right.
With the same mechanism of action, which have been discontinued due to lack of efficacy.
Right.
Those you can, the one.
So that's the only part that.
Other prescription drugs in the same pharma.
Yeah.
With the same mechanism.
So if you've already tried a drug in the protocol, fine, you would be able to move ahead.
Okay,
It's, all we're saying is just the part about trying a drug in the same class.
okay,
for the,
that's
you
the
know,
problem.
Yeah.
So I guess what I'm, from looking at it in the context, the item above it. The prescription drug required under the step therapy protocol is expected to be ineffective.
Yes.
You could say ineffective or adverse. And unless I'm mistaken, essentially get to the same exemption.
Yeah.
It's not up there. But you're, I mean, it's the item 2. Is anyone else following what I'm saying?
Sarah Teachout with Blue Cross. I think I'm following, we're just asking to remove that one yellow clause.
Yeah.
And leave all the rest of it in.
Yeah.
So
Okay.
Right.
the only thing that this would say is that we could continue to say, if there's another drug in the same class,
Mm-hmm.
please try it. But if you failed it for any of those other reasons, you don't have to.
Right, so 2 and 5 could still supersede that because 2 and 5 are about ineffectiveness or adverse effect.
I believe I understand, yes.
Okay.
You wouldn't, based on that, you wouldn't then
We would force them.
force them to try something else
That's right.
quite similar over the health professional's objection.
Yep.
Okay.
And what I appreciate and understand about this is in this, we've lumped together the insured and the healthcare professional. And if those had been separated out with different things for each, but in this context, I can see how an insured just saying, I don't even know if they know what's in the same pharmacological class.
Yeah.
So who knows, but
One I've got a complaint from was that the formulary didn't contain the sleeping aid that she wanted to take, which.
Okay.
Since you'd be okay with removing that line, because the previous one would account for such circumstances.
I'd be open to hearing otherwise, but I think any concerns are covered in the other sections when you take it up.
Yeah, me too.
Okay, are we ready to move on?
I think so.
Alrighty, next slide. This is again in the step therapy section. It's even, I think, in the same exact section that you just read. And it says, we would grant an exception, if the insured is stable on a prescription drug. And the reason that, I would like to see that removed is, there are many drugs that we switch all the time. Even though, I may have been on a drug for 3 months or 6 months, suddenly there's another drug that's less expensive for me and drugs are switched all the time. There's no particular, some drugs, stability is important. Mental health drugs, for example, you don't want to switch antidepressants or, seizure medications, for example, those are particularly sensitive, but there's a large number of drugs where that's perfectly fine. If you take, a drug like a proton pump inhibitor, let's say like Prilosec, it doesn't matter really if you're gonna take that or another one or a generic. So it's just a little too
tight.
Yeah, too tight.
So I think maybe we could look at language that tightens it around generics and
Produce. I don't have a problem taking it out. Because as long as the patient is stable on another drug, and there usually are co-pays with drugs. Yes.
should we take a recess or?
I can't recess until 6 o'clock.
I thought, sorry, it is simple with, the pro temp's office had asked for Senator McDonald and Senator McCormick to leave for half an hour from 4:30. Did that's not?
I have not gotten my emails, but it has not been conveyed to me.
Okay.
But if they're wanted in the principal's office, then they have to go. And, but that means nobody else can leave this room. no bio breaks. You might convey that to the pro temp. There just needs some urgency.
Thank you.
Okay.
Sorry that it's the.
It may be me. I just haven't, I had meetings all during lunch and I haven't gotten to my emails.
My primary first responsibility is, this is the regular schedule.
Yeah.
So I operate at pleasure of the chair of
I
this committee.
appreciate that.
May I leave?
You may be the pro temp outranks me.
We haven't been fought over since the study of
We're not,
lottery.
not in that sense.
Well, supervision, region one.
Okay, let's see if we can finish. No,
I was getting all the phone calls put.
I did not get the message. It is probably sitting in my inbox, which I have that. They should know by now. Just following.
Can I ask a question? One of the things we heard that sounded like it was just as much of an issue under this section was you have to keep calling to call back in order for someone. Do you have a standard for how often someone has to call back in for a routine prescription? So that it doesn't take provider time?
So, the great majority of our prior authorizations are good for a year.
Okay,
Yeah, so typically once a year. There are a
Mhm.
few where it's shorter. There are some where it's 3 months or 6 months, but that's, I would say 99% of them are probably a year.
and your medical board comments on, it's a medical decision about less than
It
a year.
is, it
Okay,
is.
I don't wanna keep saying your medical board, like, you're not called, I just wanna make sure we're like,
It's met.
the medical decision is being
Yes,
made.
that's right.
Okay,
Or pharmacists who know a lot about prescriptions and compounds and what are essentially the same and what are the differences. Okay,
All right, is it okay to move on? You
yes.
think? All right,
please.
let's move
We are
on,
getting-
because I only have one more point.
Okay,
And that's in the prior authorization section. And this is just an orientation slide. I wanted to just show you, this is a prior authorization activity for 2023. And I took Diva's numbers and compared them to Blue Cross's numbers for a little context. As you can see, the total number of PAs is about half of what Diva applies. This is medication only PAs.
okay.
So we do about 15,000, they do about 30,000 in a year. Our approval rate is somewhat better than Diva, we have, or worse, I'm sorry. No,
This, you do not, you do not rate is better.
right, denial rate is better. So we have about a 24% denial rate as compared to their 28%.
Is that just a flat, no, you can't have any meds, or is that a no? We would like you to try something else instead.
It's always try something else.
Okay.
Yes,
You
always.
just aren't denied
It's,
medication.
very rarely it's something that doesn't have an alternative. I would say like the vast majority of PAs are just in classes where there's multiple choices
Okay.
in the class. And we're just trying to get to the lowest cost one in the
Because
class.
it is it is,
Yeah,
driving cost, and you don't, this is the only control
yeah.
that anyone has, because the pharmaceuticals price, or the pharmaceuticals price, they have no control.
Yeah.
Is there any appeal to deny?
Yes,
does that work?
absolutely. Yes, we have a very defined appeal process. And that, would involve, we have first level appeal, we have peer-to-peer. So if there is a denial, the provider has the chance to talk to a comparably qualified provider. And then they can go to first appeal, and then go to second level appeal, and then ultimately you can go to DFR. So.
And how long does the process take for appeal?
For appeals? Sarah, I might need your help there with the numbers, with the time frame. Well, I do have a time frame slide, actually. Can you go to the next slide?
Yeah, we report all of this to the Department of Financial Regulation.
Okay,
Yeah.
So one of the things that Senator Ron Hinsdale asked for is denial rates.
Mhm.
I can provide that all because it's posted on the DFR website. For all services, not just drugs.
These are, this doesn't directly answer your question, but it does speak to what the turnaround time is for those processes. So a regular PA, what we call an urgent concurrent PA is 24 hours. Our drug PAs are always within 24 hours. Actually, most of them are within a few hours. It doesn't really take that long to do a drug PA, and most of them are all automated or electronic in the sense they come through the medical record electronically to the PBM. So they're pretty efficient. And then a post-service PA, which would be like an appeal, can be anywhere 2 days up to 30 days. So these, we have all the timeframes in the bill, we have no problem with. We already comply with those timeframes, and that is not an issue. Okay, next slide. So this is the only one that I wanted to hopefully explain. And it says that when a PA is approved, that if that drug or if that medication continues for more than a year, which is, by the way, most medications, because most medications are chronic medications for the treatment of chronic disease. So this is the majority of medications, that we shall not require another PA for 5 years. And this is this I would say is a killer because first of all, drug approvals happen hundreds, if not thousands a year. New drugs are approved, new generics are approved, new biosimilars are approved. And, you know, the cost of the drugs change very, very frequently. So to not be able to do this only once every 5 years would really greatly inhibit our ability to do formulary management. So
We don't have the same
we don't have the same.
section,
number.
so I'm just trying to
Section
find that.
3.
Your pages and lines aren't matching up.
We have the
Yeah.
House bill attached to it, attached to the original House bill. So section 3.
Oh, you have the
Okay.
official version with the crossouts on it?
Yes.
Oh,
All the Zorro.
sorry.
This is on page 27 line, we don't have lines either. It's section is number 2. Health plan shall not impose prior authorization requirements. Okay.
Doesn't say 5 year.
See that once every 5 years.
Where?
In the unofficial version passed by the House, I do see it on page 13, line 13, the end of D. The prior authorization approval more frequently than once every 5 years.
Is there the possibility that it was amended on lower? What?
No.
Okay, well, now I'm just concerned we're not even looking at.
It's really odd that you're using the official
This
version of
is
the
what we
bill.
got. Okay.
What were you, why wouldn't we use
What
the?
section in line, what section are you looking at?
So when I click on this, where it's the
Okay,
official
that might
article,
be
page 30.
Page 30.
Oh,
Okay.
Official.
About halfway down the page.
thank
Thank
you.
you.
Okay, I don't know where I was.
Okay, yeah, I see it, just in passing.
There it is,
It
okay.
is
Okay.
in section D. Okay, and that prevents you.
It really-
Prevents formulary management. And biosimilars are a brand new concept like genetics that are taking over, so this will prevent you from being able to perhaps find a better or maybe better and cheaper, but the same and cheaper.
Exactly.
Okay,
And I would say of all 3 things, this is the most impactful.
Mm-hmm. Do you have, what was it before? It didn't exist.
Well, it would just be the 1 year that we normally approve our PAs for, right?
could we go to 2?
Well, our formula
I'm
is
getting
changed.
pushback from the higher up, so I'm trying to,
Our formulas do change twice a year, but I would say the most of the changes occur at the beginning of the year in January. So, we could definitely live with once a year. But every
well-
2 years would, again, like that would be the same problem, because think
Okay.
about how many hundreds of drugs get approved in that time frame. Like
Okay.
we have Humira as an example. Humira is our #1 drug. We spend millions of dollars on Humira. There are now approximately 9 biosimilars available for that drug, and we have more coming. And we also have more coming for Stelara, which is another similar drug to Humira, and those will be coming in 2025. So if we put a PA on for even 2 years, it still would have a pretty big impact.
okay.
Can I ask kind of a random?
Yeah, and I may not get through the agenda because we do need to get the amendment to the captive out. They'll just take it from me in the morning is what, since it's a handout. But
And we were aiming for 5 for this dinner with the other committee.
I know we were, and I need to go home and pick up food.
I can ask them about
Also-
it, something.
No, that's fine. I'm also supposed to be at a meeting
I know we're like triple
for
booked.
Montpelier tonight, so.
I can just stop asking questions and just hear people, like, if we're not trying to get this bill out on the floor today.
Well, that's what the pro tem wants to know. He's very nervous about our amending it. But I think we have a responsibility.
We don't have this bill yet, so
We are not getting this bill. If we do anything, it will have to be a floor amendment. I can talk to the chair of health and welfare and tell her what we're doing. But so far, we've got some changes here that allow just the turnover in pharmaceuticals. And there's a concern about going to the Medicare edits because Medicare doesn't cover a lot of services. So there's no edits that can be used. And we haven't even gotten to prior approval except in pharmaceuticals, so I'm gonna keep moving. But I think if you can just tell us what you would like to see moved, section 3?
We would just like that removed, so at the very bottom, amend to remove section,
The highlight.
just the highlighted.
Oh, the
Yeah.
highlighted, okay, that I've got noted, all right.
Yep, just what's
Okay.
highlighted.
Okay,
So you're okay if it's longer than a year, if it was prescribed for longer than a year?
No,
Okay.
no, up to a year,
Or 1 year, whichever is longer.
they
it says.
change their formularies every 6 months.
Right, but the leading language
Oh.
says for the length of the prescription or a year, whichever is longer,
right,
do they not prescribe for longer than a year?
You have to get your.
Can I explain what that says?
yeah.
Sorry, Sarah from Blue Cross. So some prescriptions are for less than a year, maybe 3 months or 2 months. This is making us allow the PA for up to a year, even if the prescription's for less time.
Okay.
So
That is weird.
that's not how I read
That's
it.
not what it reads.
it says,
No, I mean, I'm just saying like that, that is concerning because
so we
you
try to
sometimes
oppose
wanna
that.
limit.
Yes, we try to oppose that.
Proliferation of
We didn't get very
prescription.
far, and so we're really just focused on the most important sections.
Okay.
I know you don't have much time, so we're just honing in on.
Yeah, no, that's fair, and the cost of prescription drugs is a main driver, so I'm tuning into this.
And so,
So it's the duration of the prescribed or ordered treatment, service, or course of medication, or 1 year, whichever is longer. So it's gonna be a year.
So they might get prescribed for 3 years, that would be longer than 1 year.
Are there prescriptions for 3 years?
Well, a prescription, it comes down to the way it's worded. A prescription is only valid for 1 year.
yeah,
Or ordered treatment, whatever
So-
that is.
every time you go in for your annual physical, you've gotta get all your drugs done, or the pharmacy will make you wait while they do it. But Yeah, even maintenance drugs that you've been on every year, it forces you to check back with your doctor. And
I would say this seems reasonable to me because prices do change, especially as generics come on the market and so do services, so I'm fine with removing this language.
okay,
I mean, like, I just wanna hear,
we have our doctor here, do we?
I mean, this,
Who is, oh, Jen. Okay. All
Yeah.
right.
I don't wanna override healthcare policy without understanding the healthcare policy, but this does seem like a costly provision that is our
Yeah, and this
jurisdiction.
really isn't healthcare policy, it is insurance policy.
That's true.
It's how insurance companies do.
I'm with you.
Control cost, okay. Okay, so we've got that.
And that's it,
Okay. Well, next I have Christine Coonan. Is Christine?
thank you very much.
Thank you. This has been helpful. Okay, there's Christine. I'm going to try and finish this up by 5. So Christine, the floor is yours. I have 4 wits. So I think
Good afternoon. Can you hear me okay?
we can hear you just fine. Just introduce yourself.
Perfect.
Okay.
Yes. Thank you, Senator Cummings, members of the Senate Finance Committee. I'm Christine Cooney. I'm the State Government Affairs Manager for Cigna. I cover the 6 New England states, including Vermont. Really appreciate the opportunity to be here today. Brought a couple of my colleagues with me to talk about a few of the provisions that remain in the bill that we have concerns with, specifically the prior auth alignment to Medicaid, the claims edit restrictions, and the provider policies and manuals, use and notification provisions in the bill. I did submit testimony. I sent it to you this morning. I do get into some additional detail. I will say that we have a lot of the same similar concerns that Blue Cross has already expressed, and I'm guessing you'll hear from folks behind us. We did lose my provider contracting VP, Anthony Kelly. He had to jump to another meeting, but I still have Dr. Tiffany Pierce with me, who is the New England Market Medical Exec. So let me just start, I guess, real quick on the prior authorization piece, and specifically the alignment to Medicaid. I think it's really important just to kind of take a step back and understand why prior authorization exists in the first place. And so, you know, it's really not about trying to make things difficult and adding administrative burden for providers. That is absolutely not our goal. But we're really looking at promoting the best patient outcomes that we can. We want to encourage evidence-based care. We want to make sure everybody's following clinical guidelines. We're promoting patient safety, and also as important that we are ensuring affordability for all parties. So I know you've talked about a lot of those things already. I think it's also really important to note that the number of services that there is actually prior authorization for on the commercial side is really, really small, relatively small. It's not every service. And I think, you know, really what a service that's a candidate for prior authorization are those services that could be overutilized or misused or not meet medical necessity criteria. They're considered unsafe, or they have alternate treatments that are available. So, you know, we do this process very thoughtfully. There are a number of clinicians involved in this process. We're constantly reviewing. If there is something that it does not make sense to have prior authorization on, you can absolutely be assured that we are reviewing that and taking things off prior authorization regularly. Cigna actually in the last 2 years has removed a large number of services off of our medical prior authorization list. So that's a continual process. It's always ongoing. And I think just as stewards of the premium holder and the members themselves, you know, making sure that they're not paying more than they need to for care and making sure that they are getting the right services. I think it's also really important to note that the doubling of medical knowledge has just increased exponentially, the rate at which medical knowledge doubles. So it used to be a number of years But now it's actually down to days. And if you think about COVID as an example, think about what we did not know about COVID in 2019 that we know about now, or that we knew about, within that 3-month period of time when things were happening really fast. It's just such a rapidly evolving process that we can't expect even the best clinicians and physicians to have all the information available to them. So prior authorization can also be a tool to make sure that all the right evidence and clinical guidelines are being looked at. So that's kind of more of a broad look at that. I think we need to acknowledge that commercial plans are different than Medicaid, and it's not a one-size-fits-all approach. We have to really think about the employers that are designing health plans for their employees, and they're doing that based on the unique needs, right, of their employee population. So these are companies in your districts that are trying to find the most affordable, best coverage for their employees who are residents of Vermont. And we help them do that with some of these tools like prior authorization and step therapy and some of these other things. So we have to be really careful about removing tools from the toolbox when we're trying to more broadly look at affordability for Vermonters. And I would just also note that there was an independent study done in Massachusetts by Millman that looked at the impact of removing prior authorization. And they came up with some pretty significant.
Excuse me, can you get us a copy of that study?
Yes, absolutely. I can send you that link, and I did share it with Representative Houghton.
Send it to Zane, and he'll get it for us.
Yep, absolutely. And just briefly, it came up with per member cost with a full elimination of prior authorization. So that's not what we're talking about here, but $600 to $1,500 per member annually cost impact. So, and just, again, this was an independent study. So I will send that to you just for some context. I know sometimes it's helpful to have some of those numbers. This is all not to say that we don't appreciate the obstacles that providers are facing. We know that they're experiencing administrative burdens. We know that there is burnout, and certainly there's a number of factors that are tied to that. It's not just solely because of prior authorization, but we are aware of that. We're cognizant of it. And so we are constantly reviewing any and all of our processes to see where we might be able to alleviate some of that burden. And I think when it works when it works best is when we can be collaborative with providers and really talk through, some of these solutions. Electronic prior authorization is one of those tools that we're certainly looking towards as something that may eventually help to take some of the burden off of providers. It works a lot better on it's gone a lot further on the medication side, on the prescription side. It's not quite there as much on the medical side yet, but it's definitely being worked on. And I think the more that gets developed, the more relief that we will see on providers. Again, there are a lot of things in the bill. There are a lot of other things, and I've mentioned them on the testimony as well. One other real quick thing, I'm not going to go into the claims edits because Anthony was going to talk to that, and I believe he would agree with a lot of what Blue Cross said, but also the use of administrative guidelines and the provider manual. That is really an important tool for Cigna, and especially as a national health plan, by prohibiting us from being able to make certain changes in Vermont only could really restrict us when we're trying to roll out national policy changes that we feel would be effective for our entire membership, and we would have to do something different in Vermont. So I just would ask you, to kind of pause and think about some of the unintended consequences. Again, these are all outlined individually in the testimony. Again, I could go on and on. I'm not going to. I'm going to see if Dr. Smith has anything. Say that again.
No, I think we're getting the message that there are some issues, and the fact that, yes, Blue Cross is ours, except now affiliated with Minnesota. Michigan, somebody out there with an M. And so this would require you to have different policies different ways to control cost. Here.
And just that those are an important tool. That, again, it's not willy-nilly that we make
I'm
changes,
not
and our
sure.
provider contracts do talk about the ability of us to use those. And frankly, if a provider doesn't agree with a change that's made through the contract, there's a provision that they have the ability to sever that relationship with us. So, you know, there are mechanisms for them if they oppose something that we're implementing. Again, we'd rather not get to that point. We would rather be able to work collaboratively with them. But I'll stop and just turn it over briefly to Dr. Pierce for any clinical experience that she might be able to shed on some provisions of the bill. And again, thank you very much for the opportunity to come talk to you today.
Okay, Dr. Pierce.
Good afternoon.
Just introduce yourself to the record.
Sure. Good afternoon, Senator Cummings and members of the Finance Committee. So I'm Dr. Tiffany Pierce. I'm Cigna's New England Market Medical Executive and an internal medicine doctor. So I worked as a hospitalist for Dartmouth Health and Solution Health for a number of years. I've been here at Cigna for 16 years. And what I'm going to talk through is the clinical implications of this bill, the H766. I'll let you stop me as you have key questions so that we really answer the clinical questions that you have. When you think about the way that Cigna's developed out our approach to our clinical policies, all of it is looking to say, wait, let's make sure that it's clinically appropriate, meeting the standard of care, that meaning that it's consistent with the medical literature, it's consistent with the guidelines set forth by the medical societies, and similarly, that we're looking for the most cost-effective care, but always quality before cost as we're looking at that. Our panel has internal and external specialists that are looking at each of the policies at least once a year. But if there's key new research that's coming out, we're incorporating that in our coverage policies as the literature is coming out. I know that Christine started to reference this, but when you look at the NIH data and see that medical care is changing every 73 days, or as the Cleveland Clinic points out, it's actually 800,000 articles that are being published each year. So as a practicing physician, that's a large number of articles to read, probably something that most clinicians don't have the capacity to do. Cigna's looking and aligning with the standard of care, researching those articles with internal and external specialists. When you look at, and I'm going to pivot now to talk about the alignment with Medicaid, certainly those are two different populations with vastly different needs compared to the commercial population. So as you think about it and you say, wait, it would probably be a different code set, a much more limited code set. We really want to make sure that each one of our customers are getting the highest quality of care and really thinking about affordability too. There's another component that was spiked out, and that's once the service is approved, being able to keep the patient on the same service for a 5-year period. I would highlight in both of these cases that if you're seeing the medical care changing every 73 days or just over 2 months, that's not probably very realistically aligned with that rapid change in medical care. And this really impacts as you think about rapidly changing, very expensive medical fields. So I'm going to highlight a few of those for you and give an example. Think of genetic treatments that are coming out. If you think of spinal muscular atrophy, you know, the treatment wasn't that much, but you look at it, most of the treatments are $1 million, $3 million. We need to be mindful and considerate that we're able to readily implement policies for genetic treatments cancer treatments, treatments for those with inflammatory conditions like rheumatoid arthritis, Crohn's, and similarly lab testing. The example that I was thinking of that kind of readily helps to emphasize this is as you think about cancer care. We see 20% of cancer patients are highlighted in the medical literature as getting the wrong diagnosis. Cigna's developed a consult service focused on the most complex cancers. So about the top 15% of the most complex cancers, think of those as the leukemias, lymphomas, or other complex cancers. And we're really looking and offering the doctors, offering the patients, what's the standard of care? Can we give you a consult from the National Comprehensive Cancer Network doctors or the National Cancer Institute physicians? The benefit you see is realized as the treatment recommendations are changing in 40% of cases. One of our oncologists gave me a story that just blew me away as we thought about this. So it was a woman, she'd had recurrent cancer, unfortunately, with breast cancer, and was prescribed 4 different chemotherapy treatments. Our Cigna oncologist recognized that this was extensive, not consistent with those gold standard guidelines from the National Comprehensive Cancer Network. So they offered that oncology clinical consult, and we saw the recommendation change to just 2 treatments. So when you think about it, that's a huge change in terms of quality of care, quality of life, keeping that patient from those toxic treatments. Clearly, you're not paying for those added treatments, but the extensive side effects as well. I wanted to highlight 2 for you, a number of the processes that we're looking at, not only simplifying the number of services that we're reviewing, but as you think about Cigna and ESI's work, we've really looked to say, let's make services available free, automated, that we're plugging into the physician's EMR. And so there's service, yes.
I think we've got in the picture that you know, the clinical services and care that you put in. I'm gonna have to wrap it up because I have one more witness.
Please.
And then we have a bill we need to vote out. So if you could, you know, finish up your summary, and I think we've got it. I'm sorry, but we are running up against the time wall. There's another 5 o'clock commitment. Some of us have 2. So if you could just kind of summarize, that would be helpful.
You know, I think as I would reflect on this and personally reflect on this, seeing my own sister prescribed treatment that wasn't the standard of care for chemotherapy, I would say think attentively and don't keep people on long-term treatment. Make sure that it is indeed the standard of care that is the highest quality of care and the most cost-effective.
Okay, thank you. And we have Jordan Estey.
Yes, good afternoon. Can you hear me all right?
We can hear you just fine, and thank you for hanging with us. I know you had a hard stop and then it went away.
No, I was able to make arrangements because this is a really important issue. So thank you for your time. For the record, Jordan Estey, I'm Senior Director of Government Affairs with MVP Healthcare. And if you're not familiar with MVP, you know, we're a regional not-for-profit health plan serving upstate New York and Vermont. We've got about 500,000 members total in Medicaid, Medicare, and commercial lines of business. About 35,000 of those members are in Vermont. So I'm not going to, you know, given the time constraints, I'm not going to go into the level of detail on, you know, some of the more technical elements of the areas where we have concerns. They mirror what Andrew Garland has shared and what my colleagues from Cigna have shared as well. We have very strong concerns with Section 3 on commercial use of Medicaid PA rules and on Section 2B around claims edit and payment policy restrictions. You know, there are elements of the bill that we do support, and I'll cover those as well. But I really want to highlight and emphasize, you know, where we have concerns, and I've got to start with costs. those two particular sections I mentioned, like Andrew shared, they will have a significant increase on costs for our members, for Vermonters. We estimate that just those two sections alone will require at least a 3% premium increase, which again, you heard earlier, would be on top of whatever the annual cost increases otherwise need to be. And those historically average around 10%. So now you're talking 10, 12, 13% or higher, just to cover the higher costs of this bill. But really importantly, it's not just higher premiums that we're concerned about, especially as you think about, the commercial health insurance markets and the people that have coverage in those markets. Almost everyone in those markets has some form of a deductible. Most of those with a deductible have a high deductible. So they're paying out of pocket 100% for a lot of bills that they incur before the deductible. So when Andrew from Blue Cross Blue Shield shared some of the discrepancies earlier between what Medicaid pays and what a commercial insurer pays, that is very real for consumers in that, they're going to be paying those bills entirely. So, that's very important to us. We do understand prior authorization costs money. It costs us money too. And I think it was Senator Hinsdale asked a question about costs associated with that. At MVP, we're not implementing any of these programs unless we know there's a significant return on investment for our members. And our estimates, fundamentally capture these costs and factors. And we have a target threshold of at least, $5 in savings for every dollar that gets spent to administer the program. We take a look at that annually, and certainly, we value the feedback of our provider partners and are always looking to, mitigate the areas of friction and improve their experience as well. I know this is redundant. It probably feels obvious at this point, but I do think it needs constant affirmation. And affordability is consistently the number one issue in any poll or survey about the healthcare system, or the biggest challenges people face, in accessing healthcare. Not lost on this committee and all of us that healthcare costs too much. And I think importantly, as it relates to affordability conversations in this bill, this would affect your individual and small group markets, in particularly that buy coverage through the state exchange. This is the population that struggles most with affordability, and in my view, can at least afford some of the cost implications we're talking about here. I also want to pivot a little bit and focus on something that hasn't gotten a lot of attention today, but because this committee is responsible for insurance matters, I think it's really important for you to know that, this bill is going to have major impacts on those state-regulated commercial health insurance markets, which have been steadily eroding for more than a decade now. So I think Andrew from Blue Cross pointed this out, that the bill effectively only impacts those state-regulated markets, and there's really only 2 or 3 carriers that serve those markets. And predominantly, there's 2 local not-for-profit plans, MVP and Blue Cross Blue Shield, that are in these markets. And, I think if you look at financial performance over the last number of years, serving these markets, we've lost, I think, a combined $80 million. So that's, that's concerning. And if you look at the trends between your self-funded ERISA plans and your state-regulated insurance plans, in 2010, it was about 50%, 50%. You had half in state-regulated plans, half in self-funded plans. Since then, I think the state-regulated markets have seen about a 50% drop in enrollment, while the self-funded markets have seen a significant increase. So why is that? I think self-funded markets are not subject to state laws, right? So when you have bills like this that drive up costs, that limit flexibility, limit innovation, it sends Vermonters in search of more affordable options, of better options, right? And I think, the point I would leave you with today is these trends are simply not sustainable. In terms of, I'm sorry, did you have a question?
No, thank you.
In terms of application, we're very concerned that it would be a struggle for us to implement these new requirements. So the implementation costs, we think, would be fairly extraordinary. They would require new IT systems, new configuration, comprehensive review of thousands of Medicaid rules and policies, development of an entirely new set of medical policies and procedures, which at the end of the day, only affect 5% of MVP's members. So that's not to say one member is any more important than the other, but as a small plan, we have very limited resources. So now we have to take those limited resources and invest them in standing something like this up, when we don't really believe there's much, this doesn't benefit our members in any way. And there's obviously opportunity costs there, right? That limited resources we could be spending to invest in innovations and in other opportunities that would improve all of our members' experience. You know, to the notion of alignment and this somehow reducing overall complexity, I want to point out, we think this would actually increase complexity, not decrease it. So, for example, MVP has thousands of New York members that see Vermont providers or get services from providers in Vermont, right? So we wouldn't, I believe we wouldn't be applying these changes for our New York members. So now as a Vermont provider, you have two sets of rules for MVP members based entirely on where they live or where they purchase their policy. And that's on top of the fact that none of these changes would affect the self-funded markets, which we've just covered, represent the vast majority of commercial enrollees today. So providers, I think it's fair to the question, you know, how much of an improvement would this be? And it, you know, I think at the end of the day, they're going to be facing a lot of the same problems that, you know, they claim that this bill will resolve. You know, at the end of the, go ahead, sorry.
No, go ahead, finish up.
Okay. So at the end of the day, we represent our members, we represent consumers, the cost, the complexities, the limited scope. You know, these are asking a lot of our members. They're asking a lot of Vermonters, frankly, without much in return. So access won't improve, outcomes won't improve, care quality won't improve. So I think it's important that we ask the question, what are we paying for? You know, what is actually in this in terms of value? You know, and I do want to just comment on some of the, you know, the points I've seen made, not necessarily today, but as the conversations around this bill have unfolded, nobody, including health insurers, wants patients to wind up in the hospital or emergency room because they don't or can't access necessary care. So, you know, any suggestion that insurers deny or delay care to generate profits at patients' expense, I think, frankly, in my view, are offensive and a mischaracterization of facts. You know, MVP is a local health plan. We employ physicians, pharmacists, nurses, therapists, counselors, social workers, public health professionals, community advocates, and so much more. You know, we're patient advocates and representatives. We're managing your budgets and trying to protect you from overpayments. We're helping you navigate an incredibly complex, confusing, and fractured healthcare system. We help you and your doctors understand the rapidly evolving system of treatments, devices, and services, and above all else, we want, you know, our members accessing high quality care that improves their health. Are there things that can improve? Absolutely, always. But, you know, I think our focus is on the consumer and the patient. So with this in mind, I just want to just highlight, we do support parts of the bill that do focus on the patient experience and access to vital services without delay. So when we're talking about prior authorization, when we're talking about step therapy protocols, having that exceptions process in place where the information is clear, it's transparent, and decisions can be made in a fast manner to ensure that, you know, delays aren't happening. Ensuring members get access to that care is critically important. We fully support that. We have to today, under current state law, we have to make those decisions within 48 hours. MVP absolutely supports increasing those decisions to 24 hours. You know, one example that you know I've heard shared is decisions can take several weeks. As that's delayed, a member ends up in the hospital. Again, we don't want that. That's in violation of current state law. So I would ask the question, you know, is that insurer in this example a state regulated plan? If they're not, then this bill would have no impact to that type of example. Again, our prescription drugs really support the step therapy, the notion of a step 30 process exception and ensuring our members get access to drugs. You know, there's been other examples shared about health insurers denying children's access to inhalers, but that issue is largely driven by that manufacturer pulling that product from the market so there was a shortage, not insurer prior authorization rules. You know, in fact, MVP moved to increase access. We relaxed some of the rules we had in place around inhalers in response to it. So I point this out just again, because that's another example I've heard used that it's not clear to me how this bill would improve or change anything regarding that example. So lastly, I just want to highlight one additional point. You know, we've all been working on health reform here for many years. I think we all understand that fee-for-service payment is a problem. It can incentivize the use of more services, of more expensive services, without regard to cost or if the service will materially improve care or outcomes. I raise this because I think we all generally believe there's a better way. You know, I think we all recognize that our healthcare budget is not infinite. These are real dollars. And, you know, I would raise caution and concern that this bill or these elements of this bill seem to double down on fee-for-service reimbursement, kind of reduce incentives around payment reform participation, and frankly, maybe backtracking on what has been the state's larger healthcare reform vision for many years now. So really appreciate the time to share our perspective today, and certainly happy to answer any questions or provide additional information offline.
Okay, thank you. Senator Brock, question.
Just one question. What we've heard from providers almost universally is the process of prior approvals is bureaucratic, time consuming, and with very long time windows. How does MVP respond to that?
Well, state law today says we have to respond within 48 hours. This bill would require responses to urgent requests within 24. We support that. You know, if we're not meeting those standards, we're in violation of state law. And frankly, you know, we don't want that scenario where a patient is put in that situation. So if that is happening with an MVP member, we would have concerns and would look to see what's happening and how we can rectify that situation.
Okay. Randy, do you have a follow-up?
I do not.
Okay, thank you. Thank you. Thank you, everyone, for hanging in there with us. I will try and give the pro tem bad news that we think this might be more of an insurance than a healthcare bill. And that there's a good possibility that there might be an amendment and ask him, but we aren't going to get that done today. We need to do an amendment, the one we discussed yesterday for the captive insurance on cyber kiosks and okay. Got what you're saying, sticky. So this is, and this is Senator Cummings, and to be determined, all or some members of the Finance Committee move that the Senate concur in the House proposal of amendment with further proposal of amendment. Subchapter 79, subchapter 10, section 2572, et cetera, and the wording that we are changing says, moratorium to protect the public safety and welfare, safeguard rights of consumers. Virtual currency kiosks shall not be permitted to operate in Vermont prior to July, and we, theirs was 2 years, right? We have moved it to July 1st, 2025. This moratorium shall not apply to virtual currency kiosks that are operational in Vermont on before June 30th, 2024, and I'll pass that around. I think that's what we agreed. Everything else is the language. All the other stuff is in the bill as it was brought to us.
So-
There.
You can come up with a quick kiosk.
I was a little,
If you come up with a quick kiosk in a few weeks, yeah, you're fine.
I'm fine with it if you want to add my name. I don't know if we do a vote with a floor amendment, but I'll be that.
We don't have to do a vote. I will do a floor amendment. I will put Senator Chittenden's name on.
I'm happy to be on it, stand by our work. If they do a quick kiosk, DFR will still find out about that.
Yeah.
And they will still be regulating them, monitoring them. And in fact, Senator Bray had the opposite concern that we were creating a closed market, so I think this is a balance.
Okay,
I'm on.
all right. Is everybody on?
I'm sorry.
You're on?
One, sir.
Dale, Rob, how about you, Senator McCormick?
I came in the middle of the sentence.
This is the,
It's commuted.
this is the captive insurance amendment that came back to us from the House.
Yeah,
That put a moratorium on kiosks for 2 years. We yesterday decided to make it for 1 year and to exclude currency kiosks that are already operating in Vermont on or before June 30th. So we've got 37, we might have 40. But it won't penalize those that are here. There was a concern that people have put their regular currency, invested it in these machines that might limit their access. So are you on board?
You're looking at this is gonna be the committee voting on this or
It's whoever
sponsors?
is sponsors.
Yeah, no, I'll pass.
You'll pass, okay. Senator McDonald, you pass, okay. I've got 4 of us. I will bring that up in the morning. Thank you all. If I show up in your committee and remind me I'm supposed